Thank you. Right, if I could welcome all members to the meeting of the board. The meeting is being held remotely and members are in attendance via video conferencing. This meeting is being live streamed and will also be available for repeated viewing. During the meeting, if a member wishes to speak, they will indicate its respect as requested and we will ask them to call on to speak in turn. I'm going to begin by reading the names of the members on the committee so they can confirm their attendance for the public record. My name's Liz Fairhurst, I'm chairing this meeting. Dr. Barbara Rushton.
Good morning, I'm Dr. Barbara Rushton, Clinical Chair South Eastern Hampshire and Vice Chair of the Health and Wellbeing Board.
Thank you. Councillor Judith Krajewski.
Yes, hello, I'm Councillor Judith Krajewski and I'm the Executive Member for Public Health.
Morning, Judith.
Morning.
Councillor Patricia Stallard.
Good morning, everyone. Yes, I'm the Executive Lead Member for Children's Services and Young People.
Thank you. Graham Allen.
Yes, good morning, everyone. Graham Allen, Director of Adults Health and Care here. Thank you.
Simon Bryant.
Good morning, Simon Bryant, Director of Public Health.
Steve Crocker.
Good morning, everybody. I'm Steve Crocker, I'm Director of Children's Services.
Welcome, Steve. Dr. Peter Bibberway. No. Okay. Dr. David Chivers.
Hello there. Yes, David Chilvers, GP from Gosport, Fareham Gosport CCG.
Thank you. Dr. Rory Honey.
Good morning, Councillor. Dr. Rory Honey, GP from Andover, deputising for Sarah Schofield, West Hampshire CCG.
Thank you. Dr. Matt Nisbet.
Good morning, everyone. Dr. Matt Nisbet. I'm North Hampshire CCG's Clinical Lead for Business and Partnership.
Thank you. Councillor Anne Crampton.
Oh, well, hello. I'm a councillor at Hart District Council and I chair the district's forum.
Thank you. Councillor Philip Raffaelli.
Good morning all. Philip Raffaelli, Councillor from Gosport Borough Council, one of the district representatives on the board. Thank you.
Thank you, Philip. Patricia Hughes. No, Patricia. Not yet. Christine Holloway. No. Angie Kimberley's will be joining us from about 11 o'clock. She's representing the PCC, but she's got a clash this morning. Julie Ames.
Yeah, good morning. Julie Ames energised me and I'm here representing the voluntary sector.
Thank you. Alex Whitfield. Alex will probably be joining us later as well. Rob Cole? No. Okay. Right. Is there anyone in the room on the board, deputies or that, who I haven't mentioned, or anyone who's new to the meeting who would like to introduce themselves? Mary O'Brien, I've got your hand up.
Hi, yeah, thank you. Sorry, I was a couple of minutes late dialing in. I'm Mary O'Brien. I'm Deputy Director of System Strategy and Transformation for NHS E&I, and I'm here deputising for David Radbourne.
Thank you. Alex, I've seen that you've just come in. Would you like?
Yeah, thanks, Councillor Fairhurst. I'm Alex Whitfield. I'm Chief Executive of Hampshire Hospitals, and I'm here representing the acute hospital providers.
Thank you. Ron Shields. Ron, do you want to unmute yourself? No, okay.
Sorry, good morning. Hello, Ron Shields, Chief Executive, Southern Healthcare Trust. Welcome.
Councillor Bolton, you've got your hand up.
Yes, thank you, Chairman. I'm a deputy to the board. I'm not deputising as such for anybody this morning that I'm aware of, but I'm here with great interest to hear what you've all got to say. Thank you, Chairman.
Thank you, Councillor Bolton. Councillor Perry.
Yeah, Roy Perry, same category as Ray Bolton, Hampshire County Councillor, Deputy Member of the Board.
Thank you, Roy. Councillor Manns.
Okay. Yes, I'm here as leader of Hampshire County Council.
Thank you. Lisa Griffiths.
Hi, yes, I'm here as a deputy for Anne Crampton for the borough and district side with Winchester District Council.
Thank you. And we've had another late entry, Christine Holloway. Not in yet.
Sorry, I am now in.
Okay, thank you, Christine. Sumaya, is there anyone else who's just come in that I've missed? I've got another hand up, but I don't know whose it is.
I think it's Councillor Huckstep.
Oh, Councillor Huckstep.
Good morning, everyone. I'm Councillor Huckstep for the Meon Valley Division, and I'm Chairman of Hampshire County Council's Health and Social Care Select Committee by invitation of the Chairman.
Thank you, Roger. And I see Councillor Jackie Porter, who's just come in. If you'd like to introduce yourself, Jackie, because I know you want to speak on a couple of items on the agenda.
Yeah, thank you. My name's Councillor Jackie Porter. I represent the oppositions, but I'm the opposition spokesperson for children. So I'd just like to bring the children's perspective to the meeting today in a couple of representations. Thank you.
Thank you, Jackie. Right, is that everyone, Sumaya?
We have Joe Jeffries with our hand up.
Oh, Joe?
Morning, everyone. Thank you, Chair. Joe Jeffries, Associate Director of Public Health, deputising for Simon and just observing the meeting today.
Ah, sorry. Yes, welcome. Sorry. Simon did tell me you were coming, so I'm sorry it slipped my mind. Thank you. Welcome.
No apology. Thank you.
Right. Anyone else? No? Roger, do you want to put your hand down? Thank you. Ah, Sian, sorry.
Yes, sorry, Councillor Fairs. I thought I should introduce myself. Sian Davies, I'm Consultant Public Health, Hampshire County Council. I'm here for the Living Well update.
Thank you, Sian. Right, I think we've called everyone. Just to remind you, all decisions today will be reached through a vote conducted by a poll for, against, abstain, and then for. Members will indicate their vote by clicking unmute and sharing the option they support. The vote will be conducted by a Democratic and Member Services Officer, and the result will be confirmed before moving on to the next item on the agenda. I would like to remind members that the Constitution standing orders will apply, so please keep your microphone muted unless you've been called to speak, and that to remind you, you may be visible on the screen to the public and to other members, even when you are not speaking. Sumaya, apologies, please.
Thank you, Councillor Fairhurst. We have apologies from Dr. Sarah Schofield, Michael Lane, Dr. Nicola Decker, Maggie McIsaac, and Mark Cubbin.
Thank you, Sumaya. Declarations of interest. If you have an interest in any item to be discussed today, please declare it at the time of the relevant debate. Now, if I could ask you to all look at the minutes of the previous meeting, can I ask if everyone's happy with those? Any comment on the minutes, or are you all quite happy? Christine, you've got your hand up.
Thank you. I couldn't remember how to do it virtually. Only to say that I was a bit disappointed in the minute of the discussion we had about the transport aspects to active travel, because I thought it was a conclusion from the meeting that we really should invite the transport people here so that we can have a conversation about the overlap, given the urgency of it with the development of the local transport plan 4. And so I was disappointed that that was recorded only as a somebody mentioned rather than as a decision of the meeting. Could you update me about what's happening? And is my memory at fault, or was it the feeling of the meeting that we ought to invite them?
Do you know, Christine, I can't remember. I thought we'd agreed that we would speak to them and come back at a later date.
Thank you. That's what I thought too, but that isn't what's in the minutes. The minutes just mentions it as somebody saying it would be nice to talk to them, but it doesn't actually mention as a decision that we were going to invite them to come back to talk to us.
Well, it wasn't necessarily they were going to come back to talk to us. Can you leave that one with me, Christine, and I'll look at it.
Can I jump in, Councillor Fairhurst, if that's
yes,
all right?
Yes, Maya.
I just wanted to say, Christine, that we did put it as part of the forward plan, and we did speak about it at the agenda planning meeting, and it is in for March, so we're expecting that item at that time. And I think Simon can say a few words about it. I just saw his hands up, if that's all right.
Thank you.
Simon.
Just kind of back up what Samaya said. You know, Christine, you're right. It was a really good discussion. We do know that the links to local transport plans and physical activity are key. So it has been taken forward as a piece of work. We are linking in with the local transport plan view of various people around this table. So what will the meeting in March be able to do is kind of get a bit more of a summary of where we've got to, but certainly we are feeding in as we all can to the local transport plan. So it's in progress, and we'll have a fuller discussion at the next meeting.
That sounds great, because what matters is that it's happening, not whether or not it's in the minutes in precisely the right way. So great, thank you very much. And so we'll just to reassure me, March isn't going to be too late to influence the local transport plan if this board has some thoughts.
I need to check that, but in the main, as you say, we're working with the plan. So members of the board are working with the colleagues in ETE, obviously part of the council. So we're all feeding into that process. So it's an initiative process, Christine. So in March, that'll be a good time to kind of find out where we've got to and move that forward after that.
Thank you. If it does turn out to be too late for this board to influence it collectively, I shall be very upset, but it doesn't sound like it will be. I can't imagine they're moving forward that fast.
Yes, but all the members of the board, Christine, in their own ways are responding to the consultation anyway.
Well, I don't think I am, because I haven't been given any information about how to respond. I'd be happy to respond if I'd been asked.
Okay, well, we'll look into that. I think someone else had their hand up, actually. No? Okay. Apart from that, is everyone happy with the minutes? Right. Okay. Right. Moving on, we have no deputation. And I only have one announcement, which is the COVID Clinical Vulnerabilities Index has been updated with November 2020 data published on the COVID JSNA pages, and we will make the link following the meeting. And perhaps Simon would like to have a few words on this. Simon?
Many thanks, Councillor Hurst. It's just to really update the board that we know that there's a number of kind of clinical vulnerabilities for impacting on COVID. So we've done some work just to really update that and update the data. I think we need to make sure that we use it as a system, because we know those populations who are more vulnerable from COVID. And as we've just discussed informally before, we know we're still in the midst of this pandemic. So I would urge all partners around this table to use that to help their planning for services and development of plans.
Thanks, Simon. Right, moving on to item 6, starting, living and aging well, mental health and well-being. Sorry, Simon, we're coming straight back to you. So if I hand over to you and your team.
Not a problem. I think with permission, Chair, my colleague Sue Crockman will share the slides, if that's okay.
Yeah.
I'll give a short introduction, and then Sue will talk through that presentation, if that's okay. So this presentation is really about thinking about the mental health and well-being assets, particularly thinking about those impacts on society and the community, thinking about the time and the impact that has taken. Of course, there are impacts on mental ill health services, and we've got experts around the table. This is really around the evidence of what we're doing to support communities around mental health and well-being. And we know there is elevated stress in wave 1, and obviously we're in wave 2 now. So it's really looking at some of those works and the long-term impact of those, thinking about where we are and kind of what we need to do to really improve the mental health and well-being of our population. You can see this graph here. We're all fully aware of the immediate wave of kind of people being very sick with COVID. The second wave in this sense actually refers to the kind of not the second wave of COVID, but the kind of another wave of illness in a different way. So we did restrict treatment in the first wave. And then we know that we'll have an interrupted kind of care for chronic conditions, and finally we'll be picking up the economic injury, the psychological trauma and the mental illness, and that will really come through. So this presentation gives you a bit of a summary of that for a discussion, and I'll hand over to Sue, who's got the detail of what we're going to talk about, if that's okay.
Thanks, Simon. Yeah, just to introduce myself, I'm Sue Cochran, consultant in public health with a portfolio for mental health and suicide prevention and substance misuse. And as Simon says, we know that COVID is going to have and is already having a disproportionate impact on our population in terms of mental health. And this is really playing out in terms of increasing inequalities relating to mental health and wellbeing, particularly amongst some population groups. So these groups have been identified as experiencing higher levels of anxiety, depression, loneliness and self-harm when compared to other age groups. And if we look at this list, we can see that there are groups such as young adults aged between 18 and 34, and women have also reported worse mental health and wellbeing and increased loneliness, and that there are groups such as lone mothers that have been identified as a particularly vulnerable group. So surveys in the first lockdown found that 20% of people who were unemployed said that they were not coping and had experienced suicidal thoughts, and 50% of health workers felt that their mental health had declined. We also know there's been disproportionate impact on our ethnic minorities, and particularly Asian groups have reported more mental distress as a kind of direct impact of COVID. So if we look at our priorities, I think it's important to stress that mental health and wellbeing was already an existing public health priority. So in October 2019, Hampshire County Council signed up for Public Health England's Prevention Concordat for Better Mental Health. And this outlines our commitment to working across the system to deliver a comprehensive and coordinated plan to improving mental health and wellbeing. And the response to COVID has presented new challenges and priorities, with the immediate response and following recovery periods requiring rapid action alongside our partners to support mental health and wellbeing. So these efforts have really been brought together through what we now see as our coordinated mental health plan, which continues to focus on ensuring a multi-agency approach. And we've got 3 prongs to that, which are shown on the left of this slide. So firstly, around prevention. So for example, we're looking at the determinants of poor mental health, such as financial difficulties, and unemployment, early interventions, so ensuring access to bereavement services across our geographical areas, and access to crisis care, so working with our partners and supporting communications so that people know what services they can access and where. And this is a good kind of picture of our mental health and wellbeing plan as it stands. So we recognise the significant impact that COVID-19 has had on our population's mental health and wellbeing, and we're following the key principles that guide most of our public health approaches around looking at our whole system across the population-wide and taking a life course approach, but really building on the partnerships and existing structures that are in place. Communications has been, and messaging has been, a key part of how we're delivering this plan. And I'll go into that further on the next slide. So this work is overseen by the multi-agency Hampshire Mental Health Partnership Board, which aims to work strategically to develop a holistic prevention-focused approach to mental health and wellbeing across Hampshire. So I quickly mentioned our communications plan, and this really has been a key element of how we're supporting recovery. We have different weekly universal and targeted campaign topics which highlight key messages and support and signpost onto any guidance and support that's out there. And this is designed to support the general public workforce and volunteers. So, for example, this week, our universal messaging signposts to specific resources around Christmas and mental health. And we've got a targeted campaign for young people who might be struggling to cope with stress and anxiety. We deliver this work through a multi-agency mental health and suicide prevention communications group, which aims to ensure consistency in messaging across organisations and areas. And we know that our mental health and wellbeing social media posts are achieving consistently good or high engagement. So there are posts that have resonated particularly strongly with our followers, and those include messages supporting young people, and our posts linking to the wider awareness days such as World Mental Health Day on the 10th of October and Suicide Prevention Day. On Facebook, our posts reached between 4,000 and 10,000 people, and our suicide prevention messaging on Facebook reached over 11,000 people and gained 289 engagements, so clicks and likes. So we're doing well in terms of our reach. Evidence shows that the impact of COVID on children and young people's mental health has been a mixed picture. So some children initially reported that they benefited from the protective environment at home, but we know that there's been a disproportionate impact on vulnerable children, particularly those with existing mental health conditions and special educational needs, and this will exacerbate the existing inequalities that we see. Evidence has also emerged of increasing presentations to services for young people in crisis, with children and young people mental health crisis services reporting both increases in demand, but also the complexity in presentations that since the end of the first lockdown. I've also mentioned that there's good regional evidence out there of an increased impact on young adults with elevated rates of anxiety and depression and increased rates of self-harm compared to other age groups. So the work that we've been doing around children and young people is really through our existing partnerships and work streams within the emotional wellbeing strategy. And we've been working to ensure clear guidance and communications has been made available for parents and carers around how to look after their mental health, with signposting to local and online support to enable early intervention and strengthen family resilience. We've developed a managing self-harm toolkit, providing professionals with access to evidence-based resources, advice and support. And we've been coordinating work with our education and our 0 to 19 public health service. So in developing a robust schools resource, making sure that there's digital information available through our Hampshire Health and Education website, and supporting staff in schools to ensure mental health support is available and that emotional wellbeing is integrated throughout school environments. There's also been some exciting work around using technology to support better mental health. So we already had our chat health text messaging service, and we've been doing work to promote existing apps such as the Think Ninja app, which is a self-help and knowledge app for 10 to 18-year-olds. And we kind of realised there's more work to be done in terms of working with our partners, particularly around working with children and people in crisis. So that will be the next stage of our work. Moving on to adults, work has taken place across Hampshire County Council to ensure our clear communications and signposting for support for working age adults, and this has included campaigns on everything from bereavement, sleep and substance misuse to money and debt. We've developed a comprehensive mental health and wellbeing training offer to support the development of skills and competence of the wider workforce. So this has incorporated mental health awareness and suicide prevention training, and we have a tiered approach so that you can almost kind of pick and choose what level you want to go from everything from short online access to much slightly longer plans depending on what time you've got, and we've delivered that so far this financial year to around 150 people from a range of organisations, including children's services, housing associations and the university. We've been doing some great work around workforce development, both internally and externally. So last week we launched specific guidance for Hampshire County Council staff and managers, actively promoting key mental health and wellbeing messages and supporting signposting to available pathways of support. We've been working in partnership with our colleagues around the LRF Voluntary Sector Forum and the Hampshire County Council Welfare Group to produce mental health and wellbeing and suicide prevention resource guides aimed at volunteers and their managers. And in addition to all of this, we continue to work with our partners across the STP focusing on suicide prevention. So we've got a clear programme around suicide prevention across Hampshire and the Isle of Wight, where we've been working to coordinate services such as improving access to services to age-appropriate specialist bereavement support and developing specific support for people experiencing financial anxiety, unemployment and isolation. This has all been complemented by work at a community level, so where we have specific programmes delivering training and support to groups of men through our SBS men's health programme. We've got a piece of work around recruiting and training community champions with communities particularly at risk, including our BAME communities. And we've recently provided small amounts of seed funding for community initiatives based on improving mental health and some suicide prevention at a community level. So moving on to older adults, we again know that COVID-19 has had a disproportionate effect on our older adults with increased loneliness, depression and physical deconditioning. We've run a number of campaigns with tailored messages specifically to older people, and we've also linked in with existing campaigns such as the We Are Undefeatable campaign, which encourages people with long-term conditions to stay active. We've worked closely with our colleagues in adult health and care, so we've ensured that there's specific advice available for our clinically extremely vulnerable. So, for example, there's now a direct referral route to a mental health support service set up from the Hampshire Coronavirus Support and Helpline to anybody who expressed mental health concerns on calls, and meaning that they can now access appropriate support. Mental health guides have also been developed to equip staff and volunteers with knowledge in having conversations about mental health and signpost onto services. So we're really looking at trying to skill up our workforce to ensure that they can have confident conversations with people about their mental health and signpost on appropriately. I know you're all aware, but none of this work has happened in isolation, and our team worked really hard to try to reach out as much as we can to partners across health, social care and the voluntary sector. And in turn, we've made sure that our mental health plan feeds into a number of different work streams to ensure that it remains connected with the joint efforts across the LRF, the integrated care system and the STP footprints. It's important to recognise that there's a huge amount of work that's happened across organisations and sectors to support mental health and wellbeing, and we continue to branch out. So, for example, just last week, we've been having conversations about how we can better engage with our districts, particularly around some of the work that's been happening around financial anxiety and debt. And how we can work better in partnership to ensure that we're linking up those conversations across the board. I mentioned previously that we had our first meeting of the Mental Health Partnership Board in October, and that brought together strategic partners and is a really exciting opportunity for us to lead the way in providing prevention-focused leadership across the wide public and voluntary sector system. And we're continuing to make sure that throughout all of this work, in addition to the strategic level system connections that we can make, that we're also connecting with our service user voice. So we've got a good group of people with lived experience, and we've also been working with our children and young people's team to make sure that the findings from the Hampshire School Survey are fed in to make sure that we've got the voice of the children and young people, and we're responding to what they're telling us. So, moving forward, the Mental Health Partnership Board has already shown commitment from across sectors that we can all work together to improve mental health and wellbeing across Hampshire. And we recognise the need, following the first meeting, to gather more intelligence around what's happening locally. And we'll be feeding this onto the next Partnership Board meeting in the new year to help us to scope out and identify what our local priorities will be. Our local priorities were, the Partnership Board agreed that these will be based around particular structures, so that we have committed to providing a system-wide approach to prevention of mental health problems and suicide, early intervention for those most at risk, and access to services for crisis care. And we'll also be linking all of this work up to that work that we're doing at an STP level, which is particularly focused on suicide prevention. Our work moving forward at an STP level is going to develop some of the plans that we've got in place for supporting people experiencing financial difficulties, but also in developing our coordinated support for people who are bereaved. So we know that we've got bereavement services out there, but we're going to use funding to help connect those services to ensure that we've got a coordinated approach across our geographical footprint. Finally, we've got a council-led conversation on mental health and wellbeing, which is now planned for the end of January. And the aim of this will be really to start the new year with a bang and have a good, participatory discussion around how we can further collaborate and engage with our partners around mental health and wellbeing. And we'll also use that opportunity to provide a stock take of all the work that we've undertaken so far and encourage partners to further commit to working in partnership moving forwards. So that is me.
Sue, Councillor Fairbairn, I'm just coming for a quick summary. Thank you, Sue, for that really comprehensive talk through the presentation. If you can just stop sharing for a minute, that'd be helpful. But from my perspective, this is really focusing on the mental health and wellbeing aspects rather than the aspects of particularly treating those with mental ill health, which colleagues around the table are much more expert. I can see Ron Shields on the call there. So this is to bring all that together as we signed up to the Prevention Concordat, which was just over a year ago in Ashburton Hall, and I think where we've come in the last year. So that's what I'll conclude with, Councillor Fairhurst, and happy to join the discussion.
Thank you, Simon. Can I just remind members, there's been 2 or 3 questions in the chat thing. Actually, people watching this cannot read the chat, cannot see the chat. So if you want to ask a question, please can I ask you to to raise your hand or write RTS in the chat box only. Okay, Anne, I think you were one of the first to get your hand up.
Thank you, Chairman. I would like to ask, thank you for the presentation, it was wonderful, but I would like to ask, a lot of our strategy is on signposting people to various other mental health services and organisations. Do we have any idea of how successful that's been, either in terms of increased referrals or direct engagement? And do we also know if the organisations that we're using have any statistics on how many have come from our referrals? And if there has been increased activity, how well are they coping?
Councillor Crampton, if I just start off, I'm sure others have got more information. I guess one of the things we're trying to do is really think about how we encourage people to take actions to improve their mental health being which don't require services. So thinking about the 5 ways to wellbeing and how we do that. I know that because Sue kindly sent it, we've got some information on kind of how well our social media has been received in terms of people picking it up, but then the direct link into services, that'd be kind of a self-referral, I'm sure. And obviously if someone then kind of goes out walking more, we wouldn't know that, but there's some really good work there. So I'll start off. If others have got other comments, that's.
Graham, did you want to come in now?
I did, but not directly on that question posed by Anne. I think, though, I would add to what Simon has already said, so that we know through the work that is taking place across all of our communities in supporting people in the clinically extremely vulnerable group. There is a huge amount of work being undertaken by partners in the voluntary community sector in terms of staying in contact with people that may be isolated, where impacts of mental ill health, or indeed just issues of loneliness are particularly prevalent. I wanted to particularly say, though, that in light of where we've been through the vast majority of this year, the work of the community voluntary community, along with the faith community, along with district and borough partners, along with all statutory partners, I think has been absolutely outstanding in terms of the way in which communities have sought to provide support to those people with particular vulnerabilities in their local communities. The other thing I just wanted to say, and again, it is a comment rather than a question, I do have concerns both in the here and now, but also going forward with regard to particular individuals within our communities. And I'm thinking particularly around people with learning disabilities and with autism, and also for their family carers. And what we know is, as a consequence of the national restrictions, the amount of pressure and stress that has been built up has been really very significant. And whilst there is a huge amount of support that is being provided, of course it doesn't touch everyone that's been affected over this year. I think the issue for me is that we will continue to see the consequences of those national restrictions in the medium to the longer term, particularly in those communities, so people with learning disabilities and autism, but indeed across our communities more generally. Once the pandemic starts, hopefully to abate and reduce, all of us, in terms of providing that support and those services to people, it needs to continue, if not double, in terms of the pace in which that support continues to be provided. So there will be a very long tail in terms of the mental health and stress that has been engendered by the pandemic. Those were the points I just wanted to make. Thank you, Chair.
Thank you, Graham. Matt Nesbitt. Matt.
Thank you, Chair. I don't know if anybody else has been watching The Crown on Netflix, but last night I got to a brilliant episode where somebody breaks into Buckingham Palace and finds their way to the Queen's bedroom, and there's a brilliant moment where he says, "I'm not mentally ill, I'm just poor." And so my question's about inequality. I think it's a great presentation, suicide prevention, Think Ninja, all brilliant stuff. But not so much about inequality and the roots of poor mental health and well-being. And I think my colleagues who who treat people with mental health problems would probably agree that the COVID pandemic seems to have hit our more deprived population more hardly. And I just wonder what the public health team's thoughts and maybe the wider membership of the board's thoughts would be on addressing some of those issues.
Sue, did you want to come back on that one?
Yeah, I will. So our suicide prevention programme has a specific strand on debt and anxiety. So we're working across with our partners across Hampshire, Isle of Wight, Southampton and Portsmouth to specifically look at how we can support people who become into financial difficulty. I think you raise a really good point in the fact that we know that we could talk about mental health, but actually what sits behind it is what's kind of pushing what then presents to services later on. We started to look at how we can do that. So there's been an initial pilot in Portsmouth, but we're looking to then take that to Hampshire and how we can work with our Citizens Advice Bureau workers to make sure that they always talk about mental health when they speak to people and signpost onto services. We're looking at how we can bring that into other spheres of other frontline services so that people talk about money as well as mental health in the same conversation. So I totally agree. And it is certainly something that we're looking to focus on in the next part of next year about how we can kind of bring both of those conversations together when people present. With regards to inequalities, we've got good data when we look across the region about the inequalities, but we've identified that we need to understand a little bit more about Hampshire and what we can do kind of together. So that's really going to be a focus of what we're going to bring to the next Mental Health Partnership Board around exactly, you know, which populations and which groups we should be working at in a focused way at a strategic level.
Right, thank you. Jackie, I've seen in the chat that you said you wanted to speak on this item. I've got you down speaking on the Hampshire Hospitals update at the Children's Safeguarding Board. I didn't have you down as wanting to speak on this one. However, if you want to speak, please feel free.
Thank you. I thought, sorry, I'd asked for 6 and 8. That was my last
Councillor
email.
Porter,
So
sorry,
I've
just checked the email. It says I would like to speak on the hospital and the Children's Safeguarding Report.
Ah, sorry. Okay, if you want me to wait, I will do, but I was going to relate this to Children's Services. May I speak, Councillor Fairhurst?
Yes, please do.
Thank you. I just suppose really the presentation said it all really when we looked at the effect of mental health starting at 18, although Sue very clearly went back to looking at the mental health of children as well. And I just wanted to say that the impact of delays of mental health services for children's services is being monitored by Children's Services, but the waiting list of years, not months, for assessment of neurological disabilities and autism and the CAMS list has been so long, for longer than I can remember now. And it is being monitored very seriously, and Councillor Stallard will know that too. If this were children with a broken leg, then this would be addressed more urgently. And I'd like to point out that the impact of housing in the pandemic will also have exacerbated the impact on families. So, for example, the assessment of autism, for CAMS services, if that assessment is actually made, it allows a family to have an extra bedroom for their 2 children. So that's a very serious impact on housing if that assessment isn't done. And at the moment, we've been talking about waiting lists of up to 35 months. So the point I'm just going to make is that the problem is now, and for the last 2 meetings of Children's Scrutiny, we've been told that funding is coming for CAMS, and they're hoping to get the funding. But still, at the last meeting, which was last month, we still hadn't heard that funding was there. And I'm asking the NHS when they will confirm that the funding that CAMS is seeking will actually be available. That's my question.
Thank you, Jackie. Ron, I know, Ron, you're down to speak. Do you want to answer that question as well and then speak?
I'm very happy to, Chair. The NHS part of the system actually signed off a commitment for 21-22 to invest £3.75 million in CAMS services for the whole of Hampshire and the Isle of Wight. That's a figure of 4.57. So that was a commitment that was made just a few weeks ago. that's recognising, as the councillor rightly points out, that there's still a significant sort of deficiency in terms of the services that are available and the access problems that have been described. But that will be making a fairly significant commitment to looking at the core CAM services, enhancing the preventative services and the investment in schools, but more will still be needed in that respect. And in relation to specifically autism and learning disability services, those are particularly the most problematic areas. There are also other discussions going on at the moment across the region, actually, to look at the access to crisis services for young people. I mean, what we've seen during COVID is that the access to services more generally, the follow through into the secondary services, there's been about a 22% increase is the benchmark figure that has actually been identified looking across the country as a whole. And that would be, I think, reflected in Hampshire as well. That follow through of people coming into the system is clearly then putting greater pressure on the CAM services and all of the other services in terms of access times and trying to actually rationalise priority within that. But at the most extreme end, those youngsters in the most difficulty, those in the most extreme crisis, that's the most obvious problem that we've been dealing with in recent weeks, with youngsters not being able to be accommodated in appropriate accommodation. And there is likely to be more funding coming in that direction yet, but it hasn't been concluded.
Thank you, Ron. Councillor Krajewski. Judith.
Thank you. Yes, I think that the COVID crisis has served to highlight some problems that have been there for some time. I'm thinking about the issues of loneliness and isolation, particularly in the elderly. And whilst we've in public health have always recognised the issue, I think it's now moved up the agenda for the general public, which is good because there's been more awareness of it. You know, elderly people have been dealing with loneliness and isolation even before we had COVID. I know we have an age concern group in Chandler's Ford, and for some people that one afternoon a week is the only time they go out. I went to see a resident of mine on an unrelated matter, and she hadn't left her one-bedroom flat in 3 years. I spent 2 hours there. She was very pleased to see me. But I just hope that with the public, we don't lose this. There's been a lot more volunteering during the pandemic, and I hope that when we get through the pandemic, all of those people who volunteered to, you know, phone somebody and have a chat with them and so on, that is not lost. And that those volunteers don't just, you know, melt away, but remain with us and help us with people who are experiencing those sorts of mental health problems. Thank you.
Thank you, Judith. Patricia Hughes.
Thank you, Chairman. It's been a very interesting discussion and debate, and one of the things I would just like to echo some of Graham's comments about the very long tail we're going to see with the COVID pandemic. Well, I had a range of different questions and a few reflections, and one of them would be is we seem to be speaking anecdotally, and I find it slightly difficult to understand exactly the scale of the problem. So Ron referenced a 20% uplift in calls into their services at stage 2. I think it would be really useful for us to get a feel for actually where were we in terms of numbers of referrals, where were we with the delays into our systems pre-COVID, what did that look like, and actually what does that look like now, and then as a group what are we going to do about that, because that will be an issue. Now clearly Sue and Bros Simon were talking about a whole range of services which are universal services which are seeking to prevent people getting into that first stage of need, and undoubtedly that's going to be very, very useful to our residents to try and stem the tide, as it were. But there will be a tide, and I think it will be really useful for us to understand exactly what that tide looks like, and actually as a group what mitigating factors are going to put in place to try and resolve that, because it's going to have a very long-term impact. And one of the things I just want to reflect upon, we've talked about inequalities, we've talked about economic challenges. I would just say, I think there's a major piece that we're missing here, which is actually the district councils are all in recovery from COVID. We started that work as soon as the pandemic started. So we started to look at which parts of our communities would be most affected by this pandemic right from the get-go. And a lot of us have got cabinet approved recovery plans in place, which are around economic recovery of the individual as well as economic recovery of the communities. And of course, when we talk about housing, the housing stock and how housing is created is actually invested in the district councils. So when we're having those conversations, we really do need to value the district councils and what they can deliver on your behalf as part of this broader perspective. I just wanted to throw that in.
No, thank you, Patricia. And Councillor Stallard, Patricia.
Thank you very much indeed. This is a part of the problem when you have virtual meetings. You can't necessarily interject at that particular appropriate point. So if members will bear with me, I'm going to take you back just a few minutes to the question raised by Councillor Porter. And I'm very pleased that she's raised it, and I thank you for her raising it again. It is something that needs to be constantly raised. But I'd like to reassure her that following the last couple of select committees, when issues of mental health in children, especially the CAMS waiting list, has been rehearsed so many times, and we've heard so many versions of promises put forward at various meetings I've attended, that I'm now in the process of arranging a meeting myself direct with CAMS representatives. And for those of you who don't know, I am the mental health champion for Hampshire County Council, and in addition to having the role with children's services, the lead role with children's services and young people, so there's a joint interest I have there. But I am trying very hard to push this forward as fast as we can now. Things are looking a little more positive than they did possibly 12 months ago, and I thank Ron very much indeed for his comments, that they were quite helpful. There's still a long way to go, but I would like to reassure Councillor Porter that I am, and others, that I am actioning things and will continue to press very, very hard indeed. And also, can I just add, with your forbearance, Chairman, as the mental health champion for the County Council, I was very interested this morning to learn, I'm sorry I wasn't aware of it before, that we now have a mental health partnership board. I think that's a major step forward, because it'll bring the various parties together, and that's what we need. And I will be in touch with Sue, because I would like to be part of that partnership board. Thank you, Chairman.
Thank you, Councillor Stallard. Simon, did you want to come in then?
Thank you, Councillor Fairhurst. I was just going to pick up a couple of the points. I think in one, I absolutely agree with everything that's being said. We've had a really good presentation on housing previously. We've had a really good presentation on physical activity at this board. This is really what the board is about, bringing together those key issues that impact on health and well-being. And what we've done here is highlight some of the impacts of COVID on mental health and mental ill health. And I completely with Graham and Patricia, this is going to be a long tail. And what we don't want to do is just kind of increased demand for services. Actually, we need to do preventative actions so that actually our population can recover from this. As I think Graham very eloquently said, and Councillor Groreski, we've seen isolation increasing. So how do we work together as communities to really improve that? And that's through lots of the work we're doing. So I think the board needs to be assured we're doing that. And this is just one way of doing that. And you'll see a survey coming through shortly to see how we improve some of those connections. I think the other thing is we need to be careful what we measure. I think that was Patricia Hughes's point, in the sense that, yes, we can measure waiting times and access to services. That's not measuring mental health. And it's always hard to measure mental health in the community. There's a number of ways to do it, but it's not easy. So we need to think about that and how we actually take forward those measures carefully for Hampshire.
Thank you. Judith, did you want to come back on that?
Yes, just to pick up Simon's point there about how we record things. Interestingly, I was listening to a programme on Radio 4 on the sounds yesterday, and it was talking about numbers and statistics. And talked about differences in one area of babies dying when they were born. Sorry, I've just forgotten the word for the moment, and why their area was so much higher than other areas. And when they actually went and looked at it, it was because the data were being recorded in different ways, and deaths, neonatal deaths, were being classified in a different way, and actually their incidence was actually no higher than anywhere else. So I just want to say I think it's very important that we do it, but we've got to make sure that we record all the data in the same way for them to be comparable and meaningful. Thank you.
Thank you, Judith. Steve, did you want to come in?
Yes, I've had my hand up for a long time, so I don't know why it's not showing with you, but I wanted to go right back quite a long way, unfortunately, to part of the presentation around. So we've talked about, CAM services and responses, but there is something else that we can and have been doing, and I want to just help people cast their mind back to a report that was published by SAGE on the 13th of November. It got some publicity at the time, but it's relevant to this because it tells us that they've reviewed all the peer evidence and so on, and they were able to say with high confidence that school closures put educational outcomes at risk, they exacerbated existing inequalities, and they ensured that opportunities for the early identification of problems were likely to be missed. And they were also had high confidence that school closures impaired the physical and mental health of children, and particularly so with adolescents, and that they have a particularly adverse impact on vulnerable children due to reduced access to essential services, and they had high confidence in saying that, and other lockdown stresses for children and parents, such as economic uncertainty, are likely to be exacerbated. That's all from the main scientific committee. So the obvious thing about that is that the best thing that we can do is to get children into school. Now, there is some good news on this in Hampshire, whereby if you look at secondary attendance nationally, it's at about 79% at the moment. In Hampshire, we're up at 86%, and some weeks even into the 90%. And similarly with primary attendance, nationally it's 88%, Hampshire's 93%, 94%. So the work that we're doing with schools to get children in actually is probably one of the most significant things that we can do to protect and promote their mental well-being. And I think we need to remember that and acknowledge that, and acknowledge the work that schools have done alongside colleagues in children's services to make sure that happens.
Thank you, Steve. Someone else I seem to have overlooked. Philip, did you want to speak? Philip, are you muted?
Yeah, the buttons didn't work. I think I'm with you now. Thank you, Chair. Yeah, a bit like Steve, I was up from the very beginning, and I wanted actually to pick up on what Anne had said at the beginning, but actually a lot of the subsequent conversation has helped. It was a really interesting presentation with lots of activity in it, and the kind of numbers we got from it related to things like social media penetration, and then 11,000 or whatever the number was, and a few hundred responses or likes. Actually, I'm not actually sure what that translates to in terms of actually helping people's mental health or actual outcomes. And it takes me back to where I think Anne was coming from, certainly where I'm coming from, and one or two other speakers mentioned. When we're doing all this activity and effort, it's really important before we embark on it, we know what we're going to do, how we're going to measure it, and what success is going to be, and then we look at that. And I think that's even more important when we find ourselves in a position when COVID has thrown everything all over the place. So unless we have our baselines and look to what we're trying to achieve incrementally and then measure that going along, we don't know if all of these really valiant efforts are delivering the outcomes and changes that we're looking for. Now, at this point, I'm actually not clear whether the team who's doing it have outcomes and KPIs and the rest, and they've just not been mentioned, or whether it's just been a more directed and reactive approach. But I really do think we need to decide before we do things what we expect to achieve and how we're going to measure that achievement. Thank you.
Thank you, Philip. Sue or Simon, do you want to respond to that?
Absolutely, and I think Sue will have more details, but Councillor Raffaelli, you're absolutely right. I think one of the challenges with this pandemic was it was upon us, and we were picking up the mental health impacts, as everyone said, and thinking about bereavement services. Actually, we've never had a baseline for the number of people accessing bereavement services, so we're kind of working in the dark to know what the impacts are like to be, to then start to measure that. So as I said before, it's really hard to measure some of those community impacts. We've seen our domestic abuse services taking more clients, and we've had a measure, but actually we don't have a strong measure of domestic abuse prevalence in our community except via surveys. So yeah, completely agree. And our mental health conversations that we're having and the plans we've now got in place will help us do that going forward. This is really the start of the Health and Wellbeing Board. I don't know if Sue wants to add anything.
Yeah, I would echo that. I mean, I think everybody could say that COVID came upon us and there was an initial response which involved looking at all the avenues that we had where we were already working and how we could improve and build upon what we have. And now we're getting into this recovery aspect. We've realised that we need to take stock and that we have a comprehensive mental health plan. We have a weekly meeting where we go through it. We make sure that we are, we're internally measuring what we're doing, but actually we need to now move that onto the next stage, which is linking that to our outcome indicators. So our commitment in 2021 is to actually move all this work, bring it together, which is what we've been doing now, and build it into a strategy with an accompanying action plan and measures and etc. So we're just moving through the phases really. And I take what you're saying completely on board. You're right. We need to make sure that what we're doing has measurable impact, and we're not just watching indicators on the side without relating them to our actions.
Right, Patricia Hughes, you wanted to come back? Patricia, you're muted. Okay, Patricia Hughes, you're muted. If you want to unmute and speak, your hand's up. No, or perhaps if we go to Barbara, because Barbara wants to say something, and then we'll come back to Patricia afterwards. Barbara?
Thank you, Councillor Fairhurst. So I just wanted to report a little bit on what is actually actively happening to those people with serious mental illness and with learning disabilities. In primary care, there was quite a lot of activity that was stopped as a matter of safety for both the patients and staff initially in the first wave, but subsequently in the restoration and recovery phase, the restoration of routine checks for people with serious mental illness and with learning disabilities has been put into place. And although it is very difficult because it's really, really interesting and intricate work and time consuming, there is now a facility within primary care for all of those patients who are already known to primary care to have that one-to-one discussion regarding their needs. Of course, that will include their needs around mental health and well-being, and we are seeing that there is a serious difficulty for a lot of them. I also wanted to just mention domestic abuse, which Steve Crocker mentioned, and of course we are seeing that there are people, children particularly, who are experiencing abuse or watching abuse in people who have been locked down, and those sorts of things are picked up by our social prescribing link workers who do signpost people, and of course they can spend a lot of time, and I will present a little bit about them in our next agenda item. But finally, I just wanted to say that there are a group of people who are very vulnerable that are hard to reach, and I think Sue did mention that those particularly with ethnic minorities, and of course we are going to have to reach out to them, particularly now with the COVID vaccination programme, because we know they are more vulnerable to COVID, and we do need to make sure that our champions are in the community and can actually help us to find those people, because we really don't want them to succumb. So the people with health inequalities, but particularly those of ethnic minorities, we absolutely need to know that we've got champions there in place to help us to work with them.
Thank you, Barbara. I'll go back to Patricia, if you're back with us, Patricia, if you want to speak, Patricia Hughes, but you are muted still.
Thank you, Chairman. Hopefully I'm back off mute, and apologies for my technical problems that I had with me appearing to wave my hand at everybody maliciously. I was just going to suggest whether there's action we can pick up from the earlier discussion around baselines, and whether actually an activity which we could bring forward is seeking a baseline for the data for the next meeting. And patently there is a conversation that's ongoing in terms of using a baseline to help inform future priorities, and whether we could bring that back to this group so that we could actually see what that looks like, because obviously some of that information must be already held, because actually you've got commissioned services. But I completely appreciate there'll be other services such as bereavement services where this is a new area where you might be capturing it for the first time, but it'd be quite useful to help inform us in moving this forward, this conversation forward, in terms of seeing what that looks like. And actually, if I just come back to the last piece, which is around some of that engagement with our certain sectors of our communities, it might be useful to include some of that as well.
Thank you, Patricia. Simon, I can see you want to come back on this.
Patricia, that's really helpful. May I suggest that we take that through the Mental Health Partnership Board and work together there with the experts and the right people on the table, and then bring back a kind of make that sure that's the working group and the kind of workhorse of this, so that we can bring back an update to the Health and Wellbeing Board at a future date, because I know that's the place that will be doing that work with the right partners around the table.
Okay, I think we've reached the end. So can I just say thank you to Sue and Simon. I think it's been a very valuable agenda item this morning, and I think we've been through it quite thoroughly. So thank you all very much. If I could take you to the action, it is that the health and wellbeing note the ongoing work to improve the mental health and wellbeing of Hampshire residents alongside partners through the Mental Health and Wellbeing Plan. This delivers on Hampshire County Council's pledge of commitment made through the Mental Health Prevention Concordiate. Rhys, do you want to just conduct a verbal vote on this?
Thank you, Chairman. Certainly.
Councillor Hare, should I just come in and say, just to add in Patricia Hughes's point and others about the baseline, that the group will make sure that we look at the baseline. So just to add that comment.
Do you want that to be an action that we ask people to vote on, or just?
I guess it's just to make sure people, that won't be lost in that recommendation.
Okay. Thank you. Right, Rhys.
Thank you, Chairman. When the option you wish to vote for is raised, please unmute and verbally make that clear. Okay, so firstly, if anyone wishes to abstain, please unmute. Thank you. If anyone wishes to disagree with the recommendation, please unmute and say so. And finally, if anyone wishes to agree with the recommendation, please unmute and say so.
Agreed.
Agreed. Recommendation is agreed, Chairman.
Thank you. Moving on swiftly, so we get to our break in time, we'll move to the Living Well theme focus. You have the recovery report and presentation in your agenda pack, but I'll call on Dr. Barbara Rushton to present this with Sean and Dr. Rory Honey and Julie Ames. So over to you, Barbara.
Thank you, Councillor Fairhurst. And I think that I've got somebody who's going to put the presentation up for us. So the purpose of this report is to provide an update to the Hampshire Health and Wellbeing Board on the priorities and progress of the Living Well strand of the Health and Wellbeing Strategy. And it also makes reference to some of the schemes that have been implemented rapidly as a result of the COVID pandemic. So if I can have the next slide, please. So if you remember, the Living Well priorities were to reduce the proportion of women smoking at the time of delivery, to reduce the gap in smoking between people in routine and manual occupations and the general population, to implement whole systems approach to childhood obesity in one area of Hampshire, to implement the physical activity strategy for Hampshire with a specific focus on enabling the workforce to be competent to promote physical activity for life. Action 5 and 6, I think we've covered in the previous presentation, to take a community approach to resilience, supporting the 5 Ways to Wellbeing initiative, and to work in partnership with local stakeholders to understand and take action on the wider determinants of health as a major influence on mental well-being. And finally, to signpost and encourage the systematic use of effective tools and initiatives, including digital, that will enable people to improve their self-management and provide peer support for long-term conditions, recognising the aspect of digital inclusion. So, Sian, if you'd like to go on.
Thank you, Barbara. I'm just going to give a quick overview of the slides and points for the board to take forward. So our first aim was to reduce a portion of women smoking at time of delivery. Unfortunately, that has increased. However, due to the hard work done by all our local acute trusts, we feel that that's actually due to ascertainment. So more women are being screened for carbon monoxide. And we have worked hard with Smoke Free Hampshire, the trusts and the public health teams to ensure that the referral pathways are as smooth as possible. We also offer extra services for women who are pregnant, for example, home visiting. And what we hope to do is increase the number of women coming forward in the new year with a digital marketing campaign. Now, unfortunately, we think that COVID-19 has had a negative impact on this. So I'd urge the board to ensure that we maintain focus on this post-COVID period. We know in our annual child death overview panel report, this is a key factor that we need to address to reduce mortality in infants. Right, next slide, please. Okay, our second smoking related aim was to reduce the gap between people in routine and manual occupations and the general population. And this is really reflecting the contribution that smoking has towards the inequalities in health and mortality that we see in our population in Hampshire. So we've given here some statistics, and I know I've got a further question from Patricia Hughes, which I can deal with if you'd like me to do that. I'm just going to admit now, he's right in the middle of the screen. But just to say that 45% of people who use Smoke Free Hampshire and quit successfully are from these groups. We do a lot of work with our provider to ensure that we target both our communications and marketing towards these groups and also ensure the services work for these people. Now, COVID has had a positive impact on people quitting. So nationally, we've seen an increase in people seeking services. And also we've done some really great local work around Quit for COVID, which Rory will talk about now. Over to you, Rory.
Schoolboy error, apologies. I'm going to talk briefly about two pieces of work. Both of them encapsulate the real potential and power of primary care as a delivery arm of lots of public health objectives and the ongoing value of collaborative working between the NHS and local authority partners. Quit for COVID, to start with, some of you may have seen this piece on BBC News South a few weeks back, which was embarrassing for me to film, but it's had a good impact, so all worth it. As Sian's mentioned, those who smoke are more at risk of becoming seriously unwell with COVID, and those who smoke are more likely to acquire respiratory infections like COVID. So by targeting this message to registered smokers through a text message sent from their general practice, and we know people still trust their GPs, and signposting them to local smoking cessation services, we've seen encouragingly already over 700 self-referrals to the local smoking cessation service. And with further evaluation and rollout to the Isle of Wight and Southampton planned for the new year, we think we'll increase this impact even further. We've also been approached by NHSE South East, who want to emulate our work at a regional level. So that's been really encouraging, and it's been really collaborative between Sian's and Simon at local authority public health team and all the CCGs who are very supportive of the work, as well as the providers involved. Can I have the next slide as well? So to roll straight on, because the synergies here, the Hampshire Healthy Hearts programme is even more ambitious, and it's a core programme of the ICS in preventing cardiovascular disease. So cardiovascular disease, by which we predominantly mean heart attacks and strokes, are still the biggest cause of mortality, both nationally and locally. And cardiovascular disease accounts for almost a quarter of the gap in mortality between the richest and poorest members of our society. We're collaboratively developing a pharmacist-led approach to improving both the detection and management of risk factors for cardiovascular disease. So that's your high blood pressure, your high cholesterol. And the work aligns with national programs such as CVD Prevent and the Primary Care Network, DES, which is the sort of cornerstone of what general practice is doing around the NHS long-term plan. It also provides an opportunity for us to go even further upstream and reinforcing some of that inspiring work of public health colleagues, which is tackling the causes of these causes. That's through smoking cessation, achieving healthy weight and improving physical activity. And the programme will ensure that we can do so and identify and support those practices with the greatest cardiovascular burden. And by doing so, prevent unwarranted variation across our patch and ensure that we leave nobody behind in doing so. Thank you.
Thank you, Rory. I think Sian is going to talk to this slide.
That's right. So we all know that unhealthy weight is a key lifestyle risk factor for long-term conditions and for people who are more severely obese, early death. So we started a pilot in Rushmore pre-COVID to look at what's called a whole systems approach. I think the board are well cited on the fact that obesity is a complex issue, and many parts of our systems, our environment and our behaviour impact on our weight. And we particularly wanted to focus on childhood obesity because we know that we want the next generations to grow up with as good health as possible, so we're not storing up ill health for later in life. As you can see, we engaged with many partners in Rushmore, and that was with Rushmore Borough Council, the CCG and Energise Me. Unfortunately, this work had to halt because of COVID, but I think we're really hoping to restart once our partners have the capacity to restart this. And also our plan is to roll out to another district or borough late in 2021 so we can learn the lessons and transpose them to another borough or district in Hampshire. So I'm sorry I can't report on massive progress on that, but hopefully we'll be able to accelerate that from the spring.
Thank you. And Julie?
Thank you. Yeah, I covered a lot of work that we've been doing around physical activity at the last meeting with the report that we brought forward. But the focus here is around the workforce element, and we've got 3 elements of free training for health colleagues, health professionals, social prescribers and volunteers. And first of all, we'd encourage board members to extend our reach in this area amongst your networks. I'm pleased to say we've got 41 people booked on this week and next week combined to do some of that free training, so that's brilliant. The second area that I wanted to pick up is the National Academy for Social Prescribing and the Thriving Communities programme, which was launched this month. I did mention at the last meeting that we'd bid to introduce a new regional physical activity and health lead for the South East region, but we've enhanced the investment into that role. So we've got extra time in Hampshire, Surrey and Oxfordshire. And we've got a new colleague starting in the new year, 4th of January, called Victoria Heald, and she will be helping us to extend the community activities across the area that social prescribers can use for people that they want to refer. And the final area is that we can be active, big online conversation. And again, I did mention this at the last board meeting, but we're into the last 5 days of this online conversation, which is designed to reach our target audiences, certainly into those groups of people that we know have a tendency to be less active, and in fact we would class them into inactivity. So we've asked 3 questions: what matters to you, the barriers and opportunities, and imagining our future. and it's definitely worth looking at some of the conversations if you have the time, because there's a lot of comments around safer cycling routes, but definitely around long-term conditions, pain, injury, changing the National Illness Service, and so on. So there's some really good conversations that are coming forward. My ask of board members today is, in this last 5 days, if you can give a push out to East Hampshire, Aldershot and Havant in particular, because what we have been doing through the 4 weeks of this online conversation is looking at who is contributing to the conversation, so we know exactly how the population breaks down in that sense, but where we're getting comments from, so we can cover the whole of our geography, and these are the areas that so far have got fewer comments and contributions. So if you could give a push out for that, that would be brilliant.
Thank you. So now over to me. I just wanted really to try and address the digital and self-care, self-management strand of this. So as you can see from the slide, it's quite a busy slide, but there is now a digital resource that Hampshire and the Isle of Wight primary care clinicians can access at any time, and has been very well used. And it includes educational websites, video libraries and apps, and also a lot of different self-help resources and lifestyle resources around weight and mood management that actually they can signpost anybody who approaches them within their registered population to. There's also a service finder on the Hampshire and the Isle of Wight personalised care website. And I would draw your attention to the Connect for Hampshire resource, which is a brilliant way for people to self-care and self-manage and to direct people to services. And finally, on that slide, there is a podcast that people might want to download around the roadmap for care. If you next slide, please. So just to highlight one of the initiatives that has been happening with COVID, which does involve some self-care for people who are most vulnerable to COVID. We've started what's called a virtual ward or a COVID oximetry at home ward, so that patients who have COVID positive or COVID symptoms are referred by their GP to a service close to them. They're offered the pulse oximeter, and you can see a little picture of that up on the top right hand corner, where they can monitor their own oxygen saturations. And this is an early measure of significant and severe disease in COVID. In the first wave, we had a lot of people who were admitted to hospital, and there was very little other than supportive treatment that could be given. But actually, some of those people were okay and might have managed better at home. And in order to keep the NHS resource in hospital resilient, this home monitoring in the community of patients who actually do show early signs of deterioration, so that they could be admitted for positive treatment now at the right time, is proving very helpful, so that we get the right, most vulnerable people into hospital at the right time. And if we just go on to the final slide. So it's just proved too difficult for us to show you this video, but there is here a YouTube about the video. So I just wanted to mention about our social prescribing service. So social prescribers are now available, they're link workers, and they're available within each primary care network, and they have a unique set of skills which enable them to build trust and rapport with patients in the community. They signpost patients to support in the community and support them on their journey of improvement. And in doing that, they use a strength-based approach and the what matters to me style of questioning. They're able to spend more time with patients than a GP can in their 10-minute slot. And there is now a network across Hampshire and the Isle of Wight of social prescribers. And indeed, on Tuesday, 1st of December, around 70 people from the social prescribing network attended. And that was to hear a webinar entitled Mental Health Support During COVID-19 and Beyond. And of course, the presenters on that webinar were from Hampshire's community and voluntary and mental health sectors. and that was to share the experience and expertise that there was available during COVID-19 for those people out in the community with wellness challenges. So, and the final slide. So the recommendations to the board are for us to reduce the proportion of women smoking at the time of delivery, to reduce the gap in smoking, to implement a whole system approach to childhood obesity, which has halted at present, to implement the physical health and activity strategy, and to encourage the systematic use of effective tools and initiatives, including digital, to enable people to improve their self-management and to provide peer support for long-term conditions. So I'm going to open this up for questions. We'll leave that slide up there so that you can actually understand what we're recommending. So please, if we can, in fact, perhaps we don't need a slide, else we can't see people, can we, Councillor Fairhurst?
I was going to say, Barbara, if we leave the slide up, I won't see who wants to ask a question.
No, you won't, so take it down. I'm so sorry.
Thank you. Alex.
Thank you, Councillor Fairhurst, and thank you. This is such exciting stuff, and I have to declare an interest in the co-chair with Simon of Prevention and Inequalities Board, where we've been looking at an awful lot of these things. I had a few comments and a question. So comments, the virtual ward and the COVID oximetry, Hampshire Hospitals has been really involved in that, and it is a fantastic programme, and I really think it's something we as a county should be shouting about, because we're leading the way nationally and it's being picked up in a load of other areas as well. So that's very good. The personalised care website, it's an ask really. I don't know how we get this. It needs to be a bit more accessible. So if you Google Hampshire Isle of Wight personalised care website, you do not find it. And I don't know how we can get a bit more high profile, because there's some brilliant resources on there, as Barbara mentioned. I have been talking to Fran White about that and other people, but I don't know if there's anybody who can help make that a bit more available to people. And then my question was really going back to the very first one about reduced smoking in pregnancy. And, you know, it is disappointing that number's gone up, even if we believe it's better reporting. And I was really struck by the view that actually COVID might make this even more difficult to have an impact on. And I just wonder from the experts, from an acute hospital perspective, is there anything more we should be doing with our midwifery teams? Are there any tricks we're missing here around how we persuade women to quit smoking when they're pregnant? That was the question.
Thank you, Alex. I think, as I said, our acute hospitals have been really, really positive and worked really hard to address this issue. And I mean, you know that Hampshire Hospitals Trust was the first one to really grasp it and start looking at the pathways. And we had really, really positive engagement from the midwifery teams. I think what would be good from the acute side is to really accelerate carbon monoxide measuring as soon as we can to reinforce those pathways, because the experience with lifestyle services is we have to constantly go back and reinforce, because it's one of the things that can slip. And certainly work in partnership with our provider and our public health teams. We are hoping to do a social media campaign in January. So if midwives are unable to have the kind of relationships that they have now with the women they see, then that will be another route to allow pregnant women to know the routes. And we're also going to be targeting their partners as well, because we know that the interactions in the household are really important in terms of enabling or being a barrier to women giving up. So I would just urge, Alex, that the acutes get back onto it when they're able to, and that we can really try and see that number going down. I think we have quite an ambition to reduce it by 2021. I don't know whether we'll get there, but I think it'd be really good if we reduce as much as possible.
Thank you, Sian. Can I just bring Graham in, because I think he's got some suggestion about how we could actually get a link to make it easier for people to access the website. Graham?
Yeah, by all means, happy to receive, Alex, and I can look to ensure with my colleagues and our web team that we get it displayed prominently on the Hampshire County Council COVID pages. And indeed, I think Patricia has followed up as well with some comments. So please send the link, and I'm sure we can make it happen.
Right, Patricia, do you want to add to that? Patricia Hughes.
Thank you. Yes, and it's what other people have said. So thank you very much for the presentation. But also, let's get all those links out to all of us on these calls for both Julie's respective items as well as this one, because actually we've got very broad networks ourselves, haven't we? So actually we could do an awful lot in terms of promoting these items by having those. I had a few questions. I'm really pleased to hear about social prescribing. I think that's a wonderful approach, which really brings so much help to the front line in terms of getting some key messages out to our residents. I just wondered, the question is, do we know, have we got a complete coverage of social prescribers across our footprint, or are there any gaps anywhere that we should be looking to focus our energies and efforts on? And there was a question earlier on which I think Sian mentioned and then passed on from, so I will come back to that one. I'm not sure I heard the answer to it, which was, we talked about the smoking in the manual occupations, and I think it was a 19.3% of people in manual occupations are believed to be smokers, and then it references that actually 45% of those who were successful on the smoke-free Hampshire approach after 4 weeks were in manual occupations. But my problem is I don't know how many people is the totality of the numbers of people in manual occupations in Hampshire, and actually how many people then took up the smoke-free Hampshire approach. Because if it's 100,000 manual workers, but actually only 100 of those went through smoke-free Hampshire, that's not such a success factor. But obviously, if it's 10,000 and 5,000 went through smoke-free Hampshire, it's a much better success factor. So without the numbers, again, we go back to that baseline picture, don't we? The evidence-based approach. Without those numbers, it's very difficult to assess the value and the success of that approach.
Thank you, Patricia. Barbara, did you want to come back on the?
I was going to come. Why don't we get Sian or Rory to talk about the smoking question?
Okay.
Yeah.
And then I'll talk about the link workers.
Yeah, thank you, Patricia. The reason you didn't get an immediate answer is because it wasn't an easy one. I will start by saying that the routine and manual is a national indicator. Locally, we contract manage on the third lowest deciles of deprivation, because it's a lot easier. First of all, it's a more global measure, and secondly, when we're asking providers to target certain groups and proportionate universalism, it's much easier to do it by geographical locations and by occupations. However, the numbers we have for routine and manual come from the annual population survey, which is done by the Office for National Statistics. Obviously, we haven't had a census for quite a long time, so they are generated from questionnaires. So overall, in the 8 and 9 categories in Hampshire, we have 83,100 people, we think, of which 15,789, it's very precise, but it's not precise. Obviously, there's massive confidence intervals smoked. Of those, 8.8% quit in 1 year. So in terms of our targeting, that says to me that we are getting somewhere with it. Would you like me to cover your other question? It might be worth the board hearing.
Yes, please.
Yeah, so Patricia asked about the targeting at groups and what that meant for districts. So very quickly, our provider is asked to target certain lower level super output areas. So we're very specific on the areas where people live. And in the last quarter, they visited 40 sites around Hampshire with their van, because that's the preference is to go to the people rather than chuck them leaflets and things. For example, they visited the Prospect Estate in Farnborough, Greywell Precinct in Havant. I know that they make numerous visits to Gosport High Street. So they tend to put the van where the people are. They also have a social media strategy. So again, that's targeting certain groups and demographics using social media such as Facebook. So that we tend to get people into the service that way. But obviously GP referral is also very important, as are referrals from other healthcare workers. And I can give you more detail for anybody if they want it.
Thanks, Sian. Shall I just answer the question around the social prescribing link workers? So yes, Patricia, there are link workers in all 42 primary care networks across Hampshire and the Isle of Wight. And in fact, in some of those primary care networks, there's more than one, and they all are eligible to go and join the link workers group so that they can actually learn from each other. They're a really, really great resource. So thank you for bringing that up.
Thank you, Barbara. Now I've got one hand up, but no name attached to it. Is there anyone else wishing to ask a question on this?
I had my hand up, Councillor Fairhurst. It's Peter Bibway.
Oh, sorry, Peter. I just had a random hand, but no name. So please go ahead.
Thank you, Councillor Fairhurst. I just had a comment and a question, just in the interest of time. So the comment is around some of the feedback from Rushmore. I'll make sure that as co-chair of the inequality subgroup for the CCG, I take that back. I know there's absolutely a lot of work going on around finessing the Rushmore strategy. So I'll take that back for both the childhood obesity and the physical activity sections. I just had a question around our what's our appetite around shared learning? So we have a strategy, right? You know, they're kind of very high level with capturing outputs and outcomes. But in terms of translating the strategy into a work plan, there'll be different approaches. The example is absolutely activating that community leadership function. And I just wonder whether, you know, is there any appetite for developing a network of networks around each subsection of the areas of the strategy with very specific examples and very quick, you know, snappy ones where this has worked and these are the results that we got, as opposed to letting kind of areas just come up with their own interventions? Thank you.
Sian, do you want to take that?
Yes, thank you, Peter. As you know, in public health, we're very driven by evidence, maybe overly so sometimes. I think when I'll give the example of the Rushmore work, that actually came out of a bid that we did with Rushmore and Havant for national funding. And as part of that, we became part of the National Learning Network. And the whole idea of starting with Rushmore was so that we could transfer that learning to other areas. With some of the other sort of key topic areas, we do have interest groups. I don't know whether they necessarily sit under the Health and Wellbeing Board and whether we have the right people around them. So we'll often work with our district colleagues, the CCGs will as well. So I suppose it's looking to see if the structures we have are effective, and if not, if there's something more we need to do.
And I would just add there, Sian, that primary care networks do actually work with their districts and boroughs and their own health and wellbeing situation, depending on which borough they're in. So I think there is now becoming quite a good resource there. And of course, as we move into population health management and start in the next phase in the new year, we'll hopefully be able to take some PCNs and actually make sure that they are facilitated to work together in a community of support, really. So I think you're absolutely right. We do need to get learning networks going, and that's the plan for the new year.
Thank you, Barbara. Julie, can I ask you to ask the last question on this one?
It wasn't a question, it was more a response to Peter's comments. Just to say that's absolutely the approach that we're taking with physical activity across Hampshire and Isle of Wight. And Energise, for me, is a very small organisation. What we're trying to do is build either, you know, local networks or communities of practice in order to be able to share our learning. So we've been doing a lot of test and learn, and then sharing that through various different methods. We're calling it a backbone approach to the way that we're doing things. And one of the things that we've just kicked off with a colleague in adult services is a Live Longer, Better community, a community practice that we're going to be sharing across all of Hampshire and Isle of Wight, which is challenging how we look at older people, and again, coming from that strength-based position and starting at what they can do rather than what we can do. And interestingly, through the conversation that we're having online through the consultation process with the physical activity strategy, we've got older people talking about, you know, from a position of love and care, their families saying, oh, you can't go out and you can't do this and you can't do that. And we need to change some of this narrative in order to be able to support older people better, to live longer for better. So that's a new piece of work that is just started last week, actually, and very much will build on this community of practice to share the learning.
Thank you, Julie. If I could take the board to the recommendations, that we note that the board will work towards reducing the proportion of women smoking at the time of delivery. We will reduce the gap in smoking between people in routine and manual occupations and general population. Implement whole systems when we can, the approach to childhood obesity, and we will translate that to other areas as soon as possible. We'll implement the Hampshire Physical Activity Strategy, and will signpost to and encourage the systematic use of effective tools initiatives, including digital, that will enable people to improve their own self-management and provide peer support for long-term conditions. Can I ask if, Rhys, can you take a vote on whether people will agree with this or not?
Thank you, Chair. Yes, I will just go over what we did before. So if anyone wishes to abstain from this recommendation, please unmute and say so now. If anyone wishes to disagree with the recommendation, please unmute and say so now. And finally, if anyone wishes to agree with the recommendation, please unmute and vote now.
Yes.
Agree. Recommendations are agreed, Chair.
Thank you, Rhys. I'm now going to suggest we have a 10-minute comfort break. So can I ask for the broadcast to be switched off for 10 minutes? And board members, you only have 9 minutes now. We'll reconvene at quarter to 12. Thank you. Right, welcome back, everyone. We're on agenda item 8, modernising our hospitals, the impact on population health in relation to the strategy. Councillor Porter has asked to speak about this. Councillor Porter, can I invite you to speak up to 5 minutes?
Thank you very much. The first point is that your recommendations today are to confirm how you'd like to be kept involved, and then suggest any areas that you feel could do with additional focus or input relating to population health impacts. And obviously the first one is for you to make that decision, but the second area about additional focus I'd like to just raise at this meeting, please. The 2 points I'd like to bring out are primarily the challenge of the consultation and the impact of the changes to hospital provision. The impact is generally described on adults, and I'm urging the HOSC as well to look specifically at the impact on children from 0 to 19 through maternity and children as a special subject of study. We're told that 15% of 15-year-olds have a long-term condition of one form, and we know that the number of children who need hospital help from birth and the impact of moving from neonatal from either hospital will vary according to the final choice of hospital in which they have their baby, and also how serious the baby is as a result of that birth. This isn't just relevant at birth, but all the way through many children's lives. The complication of the consultation is that the options of the 2 sites, coupled with the options of the different clinical options, is potentially confusing for the public. And I'd like to know how the hospital is actually planning to separate those 2 consultations or make them relevant to the public and make them understandable, because in fact there are 3, I think at the moment there were going to be 3 potentially clinical options, but with 2 building options that effectively makes 6 options, and I wanted to know how we're going to explain that to the public. The other area that I wanted to raise was really that this additional focus on the hospital clinical services from 0 to 18. All the presentations I've attended quite a few, have been about the excitement of the physical architecture of the building with children and discussing that with them, how to make it a children's size building and a children friendly building. And of course, I completely understand that, but not on the specifics of the way in which the new Hampshire Together will support children's clinical and mental health on the new site as well as on others. This has an impact on getting children to hospital appointments, the access to parental support beds if they're staying overnight, and the flexibility to childcare. 2 children who I knew were very close to me last year had 2 very different conditions. And one was slightly older than the other, but one needed very, very specialist care at the Royal Marsden. And of course, we understand the difficulties it has when you need extremely specialist care. But the other child just needed really good, quite intensive, but not intensive care. And there was no support in our trust for either of those 2 children. And the second one went to Southampton. And we know from experience that children of that age, or children between after post-neonatal right up to 17 or 18, effectively their parents are a very important part of their care in hospital. And so that is a very prime consideration, I think, for the way in which families relate to the hospital care they get. It also is about the flexibility of childcare. If you have more than 1 child, you need to spend some time finding somewhere for your other child to go while your child is in hospital. And also the nurses themselves and doctors and all the health staff need support for a creche. So I raise that as another subject itself. It's a very important part if you have a child that's in hospital. Within our trust, really, I'm asking the question from those points of how we can provide support for families who are not desperately ill, whereas children are not desperately ill, but for families whose children are very ill or chronically unwell and who have to make repeated visits to hospital. I'd just like that to be a special area of interest at some point for this trust and how they're going to go forward in their consultation. Thank you.
Thank you, Councillor Porter. Alex, do you want to do your presentation? Then if you want to reply to Councillor Porter, you do so after your presentation.
Yes, that would be lovely, Councillor Fairhurst. So actually, James Lawrence Parr is going to do the presentation because it's aimed particularly at the impact of the programme on the Health and Wellbeing Board's strategic objectives. So it's a bit different from ones we've been doing with HASC and other groups about the options. But then I'm very happy to pick up the questions that Councillor Porter was just asking after that. So if I could hand over to James Lawrence Parr, that would be great. And John's going to project the slides.
Hello all, as Alex introduced, James Lawrence Parr, currently working on the Modernising Hospital and Health Services Programme as Population Health Lead. And thank you, John, in the background for coordinating the slides. So as Alex has alluded to, the presentation is orientated more around some of the impact on population of the MOSE programme that we are more clearly understanding. If we could shift on to the next slide, please, John. And critically, a couple of things just in terms of context wanted to run through. One, we talk about MOSE, Modernising Hospital and Health Services, quite a lot. It was just an opportunity to reiterate what that means, because it's quite a broad programme. And secondly, to show the alignment with the Health and Wellbeing Board's strategy as part of developing services. So MOSE is a combination of programmes. In its broadest definition, it includes some of the transformation pillars in North and Mid Hampshire. It includes our emerging approach to population health, and it also includes health infrastructure plan to develop and modernise our hospital infrastructure. So the reason we've got this slide is because a couple of things. So the opportunity to talk here really reminded me that to relook at this strategy, and I was quite struck by the amount of alignment that we do have. So for an example, in terms of some of that broader work, the enablers, healthier communities, yesterday at a meeting which was healthier communities around some detailed work we're beginning to do with our communities in two separate wards, Buckskin and Andover, and even how we're beginning to measure impact locally. So we are looking at the measures that are described in your strategy document and working out how we can apply those locally alongside our other information to get really community-led responses to what we're doing. John, if we could just move on to the next slide if possible. So in terms of how does our current MOSE work support the alignment of health and wellbeing strategy? So our pillars of integrated care are described here. So we have 5 of them. So the North and Mid Integrated Care Partnership not only designed but have funded these, and these are core transformational pillars that we're currently working on, which include mental health, primary care networks and integrated care teams, which also include our one team approach. So it's not just the transformation of services, it's also the transformation of cultures and relationships that really make the change fundamental. In terms of some of the impact of these programs, there is to a certain degree some traditional NHS data in terms of what we're trying to do is shape how people utilise services, provide services that mean people stay at home for longer, and so we also reduce some of the non-elective impact on the hospital, which again is part of the strategic approach to creating solutions to the case for change that we described in our pre-consultation business case for modernising hospital. So within those pillars, we're also talking about integrated and working with a range of different organisations. Integrated intermediate care is a good example, with Hampshire County Council Southern Health working very closely to deliver urgent community response services and single points of access amongst a number of programmes. If we could move on to the next slide as well, please, John. I couldn't do the presentation without this, and I know that probably some of the people looking at this slide now will recognise this because they've been very instrumental in creating it, particularly Nicola Decker, and with Rory's input as well. So our emerging population health approach in North and Mid is gaining some speed. So at a strategic level, we're part of the process where Cerner Optum have been procured, and that will be around really beginning to look at data and information in a very, very different way. So we can actually understand our populations better and really begin to get to root cause determinants of poor health outcomes. That's also manifesting itself in terms of population health data packs, which are more readily available for primary care networks. And then we have some specific work, which is top 5,000. So we're looking at how we can best support some people who use services more frequently than others, but getting into the understanding. So the buckskin ward that I was alluding to earlier is really interesting, where there probably aren't some health and care services readily available, but in the emerging discussions, there are some real opportunities. And particularly important is that's community-led. So we're just part of the community leadership, particularly in the Andover area, will come from a local vicar. So we're joining that conversation, which is fantastic. There's also some specific work around respiratory patients in light of COVID and cardiovascular disease, which I'm sure Rory has spoken at length about at these meetings. It's a good alignment with the health and wellbeing strategy. I'm going to move on to, I guess, the core part of what I was asked to do, which is really describing some of the impact of what we're doing. So as part of really developing the business case for modernising hospital, so we also have to look at what our statutory responsibilities and duties are. And part of that is to do an integrated impact assessment. So we have an external organisation called Mott MacDonald, who have completed stage 2 of an integrated impact assessment. So this is really beginning to look at our populations in detail. We have to be mindful that the study area we're talking about is nearly 1 million people, which is far bigger than the core Hampshire Hospitals catchment area. This really reflects any historical use of Hampshire Hospital services, so could it include someone who potentially used emergency department for once or twice as they were on transit through the area, as well as people utilising services more frequently. So the integrated impact assessment includes all protected characteristics. So addressing partly the comment that came before, it includes age, and it looks at age in different segments as well. And we look at the impact of potential options or services, changes to services across all of those different aspects of our protected characteristics and populations. For the purpose of this meeting, what I've done is and mindful we're in the process of finalising options we propose to take forward to public consultation, which will be announced prior to the consultation beginning. So we're in that process. So what I've done mindful of that is pose the question. So if the North and Mid system had an acute centralised hospital and a main local hospital model, the potential impact on our population could be. And I'm just going to run through some of that, so hopefully that addresses the question. So on that model, our integrated impact assessment has highlighted that we would improve patient outcomes. And we would do that from several different angles, partly because of workforce. So in our case for change, we described some of the challenges of workforce across multiple sites. So we'd be able to streamline rotas, 7-day working. We could also reduce some of the variation in those workforce challenges and consultant presence. And there would be a critical mass of some services to be able to deliver them more effectively, which can be correlated to improved patient outcomes. Within the integrated impact assessment, there is also a lot of links to research evidence base to substantiate the impact and analysis that has been completed and continues. Also, separation of low complexity elective surgery would result in reduced cancellations, reduced length of stay and infection rates. So they've described some of the potential impacts in terms of patient outcomes. In terms of health inequalities, so our integrated impact assessment starts by describing that areas with more deprivation tend to have higher utilisation of health and care services, and therefore it is likely that those areas would potentially experience the benefits of a new model of care that meets those needs. Throughout this, though, what we also have to consider, and I'll come to it shortly, is the impact of travel time, and potentially centralising some services and potentially looking at different sites. There may well be some impact of travel on some people. I'll come to that in a second. Workforce is also a key consideration. So again, the impact assessment has identified some positives, which include creation of sustainable rotas, working patterns, different training opportunities, so people actually working really together, and also increased motivation through working in hospital facilities which are fit for purpose, support delivery of the clinical model. There's also some aspects in terms of being able to access green space, health and well-being, and the importance of that in terms of staff well-being, also recruitment, retention, and how we can link into communities as well as part of that recruitment and retention too. Again, possibly for some staff where there may be a change of where their base is, there could be some adverse impact. Sustainability, so this also includes aspects to do with air quality. And really, this is about also identifying opportunities for the work that we're doing that could also have an impact on our population in a different way. So Winchester Hospital is interesting in terms of Romsey Road, which is an area where the nitrogen dioxide annual mean levels do exceed acceptable levels and have done for a number of years. And this is also an area where there's some residential properties, let alone a large workforce. So those are important factors that we absolutely need to consider in what we're doing with this particular piece of work. From service delivery, again, if you design a fit for purpose model, then improved patient flow, capacity of service, all of those things could have a positive impact. What we're also mindful of is what potentially could be an impact of transfer between hospitals. So currently we're exploring with South Central Ambulance Service and a number of other organisations. We're working together to actually understand what a potential impact could be, and also we're picking up from learning, particularly from Dorset, case reviews with lots of clinicians so that we can fully understand any impact, but also work to design some mitigations that we can build into our service delivery moving forward. I'm nearly there. I recognise I only had 5 minutes. I'm just going to talk briefly about transport, accessibility. By nature of different sites, then I'll start again. Having different sites, then there may well be some impact on travel for some of our population. Currently, we've looked at that in 15-minute slots. So what's the impact by public transport, by car, by blue light ambulance, in terms of the cumulative proportion of patients or people that can access services within 15, 30, 45 minutes and longer for public transport. Public transport is a challenge because trying to work out what the impact of public transport when some of the infrastructure might not be in place that could well be in 5 years' time is a little challenging. However, we are understanding that potentially there could be some increased amount of the population who would need to travel 15 minutes. But when we look at 30 minutes and 45 minutes, it's reasonably in line with where we currently are at the moment. We're doing a far more detailed piece of work to understand where that is, and we're also identifying populations that may be impacted more than others, and we'll continue to find some mitigating actions to support that. I'm going to pause there because I recognise I've just spoken at you.
Thank you, James. Shall we pass back to Alex?
Yes, thank you, Councillor Hurst. Thank you, James. So the specific questions that were asked at the beginning around, so firstly, just to land people, we kind of assume everybody knows this, but you may not all be quite so embroiled in this as we are. We have announced 2 possible locations, junction 7 of the M3 and the current Basingstoke Hospital site for our New Hampshire hospital. That we are, as Councillor Porter said, consulting on those 2 options. We also have a variety of clinical models, and much earlier in the year we came out with 8 different combinations. We've had quite a lot of feedback that was all very confusing, and so we're actively working on simplifying those so that when we come out to public consultation in January, it'll be a bit more straightforward. And there is this real balance between having too many options, everyone gets confused, but then at the same time saying, well, you've already made up your mind because you're not giving us a chance to give comments. So we're trying to get that balance right, but we absolutely acknowledge that, Councillor Porter, is something we need to do. And then the specific about children, and I was particularly struck by the concept of children who have repeated visits to hospital. So I do want to emphasise, and I think Matt Nisbet's on the call and others may want to say more, but our real drive in this whole programme is to provide as much care as we can close to where people live. And children are an absolutely brilliant example of that, where our hospital paediatricians for quite a long time now have been working with GPs in villages and towns across Mid and North Hampshire to see children in their local GP practice with the GP next to them. And so the child doesn't have to go to the hospital at all. And, that's the ideal. And then we recognise that there are occasions where you do need to come to the hospital because of the kit that is involved, or because people are so poorly that they need sort of 24/7 nursing care or whatever it is. And in those circumstances, which should be rare, that's where we want to get this absolutely right with our new model of hospital configuration. I also was really struck by your point, Councillor Porter, about being clear through the consultation of what the impact is on children and on the services for children. And we have had through the engagement a whole load of information about things like parental support beds. We had it very strongly for neonatal parents when babies are first born, but also for children who need to be in hospital. And I have seen a draft of the document, the consultation document we're pulling together, which will be coming out to the public to explain, hopefully in slightly easier to understand language than some of the more technical documents, kind of what the options are. And there are sections in that which are about, so if you're a child who feels like this, what's going to happen to you in the new proposals. But I will take it back to the team to just say, have we got enough about children in there? We've definitely got some, and we've got adults and older people, but I'll take that back to the team. Thank you.
Thank you, Alex. Councillor Mann.
Thank you, Chair. My comment is a slightly out of the box one, and that is, are the sites that we've selected, or you've selected, Alex, and you'll probably understand why I'm making a comment like this. Will they have provision for a helipad? Because quite often new hospitals are built, and then that's an afterthought. And I think, bearing in mind where this hospital is likely to be in Hampshire, it might be a good idea to just make provision for that from the start.
Thank you, Councillor Mann. I will make sure that is included. It's obviously a bit more straightforward in a greenfield site potentially, and I know that when the sites were looked at, access to them was important. So there was one option quite near the Poplar airfield, I think at one point, that we said we'll no because you couldn't get air access over the airfield. So that was taken into account, but I will make absolutely sure that it's in there.
Thanks very much, Alex.
Thank you. Simon?
Thank you, James, really helpful. I guess for me, there's something really pleased you're measuring inequalities, but actually let's build it in at the start. So you've got, I think you mentioned 5 programs about integrated care programs and planned care, but let's have a program around prevention and another one on inequality, because actually if we build it in at the start, we're going to succeed. If we just measure it, we'll find we haven't done it. So I'd really be keen that we have some programs that think about how do we tackle inequalities with this brand new opportunity to do it, rather than just think, oh, I wonder what the impact, because we know the impact will be that those people who suffer inequalities don't get there. And really, how do we really build prevention as a key part? Now, I know many people when they go to hospital aren't well, but how do we think about physical activity options? How do we think about smoking cessation being central to this whole building so that actually people can give up smoking. So those things I think we could build in at the beginning. And I guess I'm slightly worried that there's not a programme thinking about those, because there's other programmes that we traditionally think about: planned care, elective care.
Could I respond to that?
Yes, certainly, James.
Very briefly, really good point. And I think some of the work we're doing at ward level is beginning to show that. And what we understand is information we've never understood before. So an example of one of the wards where there is a challenge to access some types of care, including primary care. So you can either take 2 buses to get to some care, or you can take 1 bus that goes past the emergency department. But there are some opportunities in the local health, community settings, and emerging conversations would help that. So we are building that in alongside as part of the MOSE programme to work up the sort of population health inequalities approach. And I guess that's also sort of reflected in me being a population health lead, but working as part of this programme too. But take your point, and we'll make sure that we do that.
Thank you. Thank you. Christine, I think you're next.
Thank you very much, and thanks for a very full and interesting report. I just had 2 points I wanted to make. The first one ties in with Simon and the inequalities. I was struck when I looked at what you were saying about the benefits and disadvantages of the options and what was said in the consultation with the link in paragraph 12 about transport. Because you report that concerns about transport came across strongly. And I'm emphasising this because I think that from the point of view of the random member of the public, they're not necessarily going to have very clear ideas about what's going to provide them with better hospital care, but they do know what's going to affect their whole lives. And that's why transport always comes up high. Now, you said that looking at it, for example, people who had to travel for 30 or 45 minutes was more or less in line with where we are now, giving the impression that therefore you weren't really that worried about it. I would start from the other end and say the current situation about travel to the hospital, both for people going, I mean, for anybody who isn't having to go in an ambulance, the current situation isn't good. And what you've got to do is seize this opportunity to improve it. So I wanted to say, could we please have your assurance that you are seriously considering how you can respond to patients' concerns and actually make things better? And if that means subsidising or putting some money in to help one of the commercial providers subsidise a bus, well then think about that as a potential cost. My other comment ties back to Jackie Porter's at the beginning, which is about consultation. Originally, when I looked at the report, I was a bit alarmed because there's a heading above paragraph 13 that says co-production that didn't mention the public at all. I thought I wouldn't have really called that co-production, but that's sort of minor point. What I was more concerned about was that from the point of view, again, of a random member of the public, the situation about hospital locations is incredibly confusing, not only because the future is unknown, but also because things have been changing so often. Now, that's not anybody's fault, but it means that if you come across something that says consult about the local hospital, your local hospital or future hospital provision, you're going to think, what? But I already replied, 2 years ago when there was that other consultation, and I think people are really confused. So I wanted to make a plea. The consultation that you're starting in January, can you please somehow build into it that we are starting again, the story so far, something that explains to people why you're asking them yet again. And who are you getting to work out how to phrase it? And have you got the voice of an ordinary person who doesn't speak health and social care jargon involved in suggesting how to describe it?
Thank you, Christine. Alex or James?
Shall I start, Alex? You're on mute.
Yeah, go ahead. And then John might want to say a bit about the consultation, how we're making it easy to understand.
Okay. So apologies if I diminished the importance of transport. It's not that way at all. It is a fundamental thing that we are looking at because of the potential impact on people utilising services. So it is incredibly important. What we're also very mindful as well is there's a difference between analysing data and saying a travel time is so many minutes versus the reality of driving somewhere, finding a parking space when it's chucking it down with rain, you've got children in the back of the car and it's really busy, very different. So we're also incredibly mindful of the real experience that people currently have and what we'd like that to be in the future. And that's also part of the design piece as well. So apologies if I diminished that, it is incredibly important. Should we bring John in just on the consultation piece?
May I just say one very quick response to that? I understand most people attend hospital in a car, but from the point of view of public health, you do need to be thinking about the encouraging people not to. And from the point of view of inequalities, you need to be thinking about the people who don't have a car and can't afford a taxi.
Completely agree. And as you've alluded to, it's a real opportunity to look at how health and care services can be provided in a different way, as Alex alluded to, in a different setting, some digital, but absolutely with a different workforce that really addresses needs. So that's part of the overall sort of considerations we are really beginning to look at, and part of some of the case reviews we're beginning to do with a number of different organisations to explore that further.
Thank you.
John.
Hi everyone, I'm John. I'm the head of comms and engagement for the Hampshire Together programme. So just on your point about consultation, yes, we will be obviously trying to make it in as plain language, plain English as possible, and we have a patient panel who will be running our documents by before we go out. That's how we're planning to do that, Christine. So thank you for your point. It was a good one, but we do have some stuff. We do have some plans in place to make sure we make everything as easy to read as possible.
Thank you. Julie.
Yeah, hi. Thank you, Chairman. It's just building on some of the previous points that's been made, because when I read the report, what struck me was the element around inequalities. So I think it's around about page 55, paragraph 11.2, and it talks about journey times and the accessibility by people to the sites. And I think it reflects it somewhere in the paper around it being marginally adverse. But in something you said, James, in your presentation was around people from low socioeconomic groups who use these services more frequently are going to be potentially impacted more by the location of those sites. So it goes back to Simon's point, I suppose, about building inequalities in. And so would you have a weighting around some of this assessment linked to inequalities?
That's a very good suggestion, and one we can certainly take back. In the paper, what I've given is, I guess, the summarised version. There are huge appendices, maps, all sorts of information that we're currently exploring at the moment. And part of it I alluded to earlier in terms of what we're beginning to find is that some people, when in that split second of decision making to say I need to access particularly some urgent or emergency care services, do I hop on a bus, 2 buses or 1 bus, and where's that going to take me? So all of these sorts of things that are beginning to merge, we absolutely need to bring to the surface, engage with the right people to get the right solutions. So yourself, Simon, are absolutely right, and we'll make sure that that's taken back.
Thank you.
To add to that in terms of what James is saying, the analysis of travel times doesn't just say how many people can get to junction 7 in this time, how many people can get to Basingstoke, how many people can. It has them broken down by how many people in the most deprived wards can get to this site by public transport, by car at peak drive time, or by car in the middle of the night. How many people over the age of 65? How many people from black and ethnic minorities? How many people who we know have got others? So there is vast amounts of data. Personally, when you start looking at it, you slightly start drowning in the kind of sheer volume of numbers, but it's absolutely there in the analysis to try and understand the impact on a whole range of different groups of people. Yeah.
Thanks, Alex. Matt, do you want to speak?
The first thing I wanted to say was just to reassure the board, really, that as you would expect with any kind of system redesign project, that myself, Dr. Nicola Decker, and a range of other GPs are also involved in kind of providing input to the design. And the second thing I wanted to say was I just wanted to pick up on, again, on the things that Simon was saying about building in inequalities. As James has said, we're alongside the MOSE project, we're doing a lot of work around some of our more deprived communities, and James has mentioned the one in Buckskin in Basingstoke. We've got other deprived communities like Winklebury and Basingstoke where we're considering health provision. As a CCG, there's always a lot of pressure from public and elected representatives to build a doctor's surgery, and the conversation that we're having with elected representatives is around encouraging them to think about services and access to services rather than buildings like doctor's surgeries. And it would be really helpful if there was somebody from Simon's team that we'd be able to link in with to help us understand the health needs of those kind of populations, because we think they're probably more around things like alcohol, substance misuse, access to health visitors, rather than the kind of things that a doctor's surgery might normally be able to provide.
Thank you.
Very happy to, Matt.
Simon, yeah. Simon, do you want to come back?
Very happy to connect on those kind of things. And I think, as you're saying, Matt, as we develop these things, I think we need to really think even further around how we work as a system, because I think you're right. How do we really integrate I'm not even going to say our drug and alcohol services, our approach to drugs and alcohol, thinking about licensing, thinking about all those other aspects that we can have a really positive impact on, which will improve the health of the population. Because yes, we can make sure it's a drug and alcohol service, but that's not going to really tackle the problem. And how do we do that together? And we work, across that. So really happy to play into that conversation.
Thanks.
Thank you, Simon. Judith.
Thank you. Yes. Alex, you'll remember that I expressed concerns about accessibility and affordability of access at the last HASC meeting. I still have those concerns, and I agree with Christine Holloway. I think what she was saying was that perhaps the status quo on journey times isn't really ambitious enough. We need to get better accessibility. Yes, I appreciate that you're looking at junction modifications, junction 7 and all that sort of thing. But in his presentation, James did say that the infrastructure is a challenge and may not be in place when the hospital opens, which does concern me. I mean, at the HASC, I think you or one of your colleagues said that there was a rapid transit system being planned for Basingstoke. Well, I doubt very much whether that's going to be ready. And it is important that all of the infrastructure is in place so that people have accessibility from day one. Talking about bus services, I represent a division in Chandler's Ford, and there used to be a bus service from, it started from Chandler's Ford to Southampton Hospital, and I think in less than a year it stopped because it just wasn't viable. And talking about having the right framework in place before a new hospital opens, it's great to hear that a lot of treatment and so forth can be delivered more locally and closer to people's homes and in primary care settings. But, can you give assurances that all of those settings and all of that infrastructure will be staffed and adequately resourced when a new hospital opens? It's a bit like in planning terms. We've seen in the past where housing developments are built and then people have to wait ages for the pavement that links them to the nearest village or the school and all that sort of thing. The infrastructure has got to be there from the start. And finally, on consultation, yes, again, and I can draw the analogy with planning. People think if they've commented on one planning application that comment is carried forward to subsequent applications, whether it's a small development or a local plan. So I think it does need to be made clear that this will be a new consultation in the new year. Thank you.
Yeah, can I pick up a few of those points? I think that just on the last one, there will of course be a planning application later as well. So there will be another consultation, which is a planning one, which is very different from a consultation about service design. So the access and the infrastructure. So I know I keep saying this, but I really passionately believe people will have shorter journeys because we will be doing more stuff close to where they live. But there may be a slightly longer distance to travel for some people, not for all of them, for the acute hospital care, and it's that balance. And we've got a very articulate cardiologist, Dominic Kelly, that some of you may have heard speak about cardiology, and he talks about how kind of 8 years ago now, we centralised the emergency cardiac service in Basingstoke, between Basingstoke and Winchester. So if you have a heart attack in Winchester, you will get taken to Basingstoke, where 24/7 we can get you into a special operating theatre called a cath lab, and we can put a stent, a balloon, in your artery within an hour and a half of you having picked up the phone to say, I think I've got a problem. We couldn't possibly staff that in 2 locations to the same level of expertise. And what he said what people don't realise is because we're not trying to look after acutely unwell cardiac patients in 2 hospitals, they can spend some of their time providing that acute service in Basingstoke, but they also have more time available, because there's only 1 team, not 2, to do clinics in Andover and clinics in Alton and clinics elsewhere. So actually, for the outpatient services that are the much more frequently accessed services, the fact that you've centralised one bit gives you capacity to do more local services for the lower acute but more frequently used services. So it is going to be that real balance of how we sort of say to the public, our vision is that you will travel less, because the things you do most often, which are day case surgery, outpatients, all of that, you will be doing locally, ideally digitally. You won't even need to leave your home if that's your preference, recognising that not everybody can use the digital services, but or at your GP or in your local hospital, even if that's Andover or Alton. So I think it's that balance that we need to try and communicate, because it does allow us to free the clinicians up to do more stuff locally if they're not trying to staff 2 super acute services. In terms of the infrastructure being in place before the hospital, I do think this is really important, and we've had fantastic support from Hampshire County Council, and I would like to, call out Felicity Rowe, who I think is on the call as well, who's kind of taken real leadership in this and has enabled us to have conversations with both Hampshire County Council, Basingstoke and Dean Borough about our 2 sites which both come under that borough at this stage, and Highways England. And called made sure we've got everybody together to really think about what the transport infrastructure needs to be. We're not planning, we don't think the new hospital will open until 2028, so we've got time to do some of this, but some of these things take a lot of time. So it's really good that we're getting up ahead of that. But we really appreciate support from Hampshire County Council and other colleagues.
Thank you.
Thank you. Matt, is your hand still up, or did you want to come back? No, okay. Rory, did I see your hand up?
No, I popped in. It's been answered. Thank you, Councillor.
Okay, thank you. Philip.
No, thank you. I was just going to ask Alex, there was a long-running debate between Portsmouth and Southampton about acute vascular surgery services. This went on for some 10 years. Ultimately, I was asked to chair for NHS England the public consultation with that, and all of the concerns that came from the public were exactly as we've heard just now. It's been put in place now to have 1 centre, but with much more in community care and outpatients than the rest. And 18 months down the line, I hardly hear anything from people except they're now getting the best appropriate care in the most appropriate position, and the clinicians are so much happier and able to deliver even better service. It's not a new argument, and I absolutely with everything that Alex said.
Yeah, thank you, Philip. I was well aware of that discussion over the last 10 years. I don't see any more questions. Can I take you to, I think we need to have a bit of discussion. We need to confirm how we'd like to be kept involved in the consultation process.
Councillor Fairhurst, I think Councillor Huckstep had his hand up.
Oh, sorry, Roger, I didn't see, I still don't see it. But anyway, Roger, off you go.
Yes, thank you, Madam Chairman. I'd just like to reassure the board and public listening that Hampshire County Council is taking a very robust interest in this project, and as such, at its last full council meeting, it established a joint HOSC with Southampton City Council, and we'll be having our first meeting on the 18th of this month to, as it were, put our ducks in a row. And then once the new year has started, we will be engaging with the project in order to scrutinise and oversee what it's doing. Now, that committee will have the facility of accepting representations from local authority councillors across Hampshire, and also deputations from anyone who wants to make a deputation. So there will be opportunity to probe into the depths of what is going on in a robust way, and hopefully as a result of that process we'll end up with a wonderful, wonderful project in whatever year it's going to be.
Thank you, Roger. Julie's just asked, and members of the public might also want to know what the HOSC is. It's the Health Overview and Scrutiny Committee, which looks into matters and reports back. So that's, if anyone didn't know. Can we go back to how we'd like to be kept involved in the consultation process? I mean, Alex, we would like you to come back. Perhaps we would quite like to look at your consultation documents before they go public, if that's possible. James, is that all right?
Fine.
Councillor Fairhurst, I don't think that we will be having another health and wellbeing board before these go public, very likely.
Okay.
So, no.
Could they be distributed to members then of the board so the board can look at them? Sorry, Alex.
It could be, yes. So the timings, and Barbara's right to intervene because it's a CCG-led consultation, and the documents will go public, assuming we get all the various approvals from NHSEI and various other people. We have to tick their boxes. If we get all of those, then there are plans for a public board meeting of the CCG and of Hampshire Hospitals, but actually the CCG one's the most important one for this bit, in the middle of January, and it will be the publications of the papers for that board meeting will be when they go public. So let us take away and just have a look at the timelines and see whether we are able to send them to this group ahead of that publication. But we haven't got long because we'll probably be publishing them, you know, early January in time for the CCG board meeting.
Okay, thanks, Alex. But it would be good if we had sight of them. Thank you. And board members, do you suggest that any areas that require additional focus or input? Simon, you're probably the one to answer this, relating to population health impacts.
Thank you, Councillor Fairhurst. I think we've picked most of those up in those discussions on how we really think about the population's prevention and inequality. So absolutely need to do that.
Yeah. Okay. Graham, sorry, you want to speak. Graham.
Yes, thank you, Chair. It's just really a point of slight technical detail, but I think it's an important one given the joint HOSC process that's been described by Councillor Huckstep. The timeline clearly in terms of the public consultation and indeed input and influence from this board and indeed others. There are local government elections next year, which will mean there will be a pre-election period. and that may well overlap with the consultation period. So to some degree, as a board and through the joint HOSC-HASC process, we just need to be mindful of that, I think, as we go forward.
I think, Graham, the timelines have been devised so the consultation period finishes just before PERDA for the local elections. And this is part of the reason for us being so keen to get all the documents signed off by early January so that there isn't a clash with local elections.
Thank you, that's really helpful.
Thank you.
Sorry, just to clarify, the current plan we're looking at is to actually pause the consultation for PERDA rather than we won't be able to get the 12 weeks we need to in before PERDA starts in earnest. So we'll have to do some and then pause it until after the elections. That's the current thinking.
Thank you, John. Barbara, did you want to come in then?
No, my point's been given.
Thank you. Alex, any final word, Alex? No?
Only to say it is an incredible opportunity, and we all of us need to work to make sure that we improve the health and well-being of our population through this opportunity, and that's what we're absolutely determined to do. So all help and comments so appreciated, because I know we're all after the same thing, which is the benefit of our population. Thank you.
Thank you, Alex. I think all remains is for me to ask Reese to conduct a poll on whether we're happy with what we've said. Reese?
Thank you, Chair. I'll try and make this one a bit quicker. If anyone wishes to abstain on this recommendation for item 8, please unmute and say so now.
I'll abstain only because I'm very involved with the programme, so I don't think it's really fair for me to vote on it.
If anyone disagrees with the recommendation, please say so now. And if anyone agrees with the recommendation, please unmute and say so now.
Agreed.
I agree.
Agree.
Recommendation is agreed, Chair.
Thank you, Reese. If we go to agenda item 9, first of all, I'd like to welcome Derek Benson, who's the independent chair of the Hampshire Safeguarding Children's Partnership Board, to the meeting, and perhaps if he would like to present the annual report once Councillor Porter, who has asked to speak on this, has her 5 minutes. Councillor Porter.
I can assure you I won't take 5 minutes, Councillor Fairhurst. I just wanted to say that I'm really pleased this paper is coming to this board, and I just wanted to record our thanks as councillors across all parties, to say thank you to the County Council for their hard work in maintaining the high safeguarding role that we have, but also to all the teachers, childminders, carers, all of the rest of the population that do have involvement with children, including sports coaches, etc. It's been a particularly difficult summer because not everybody's had the contact with children that we have had in the past, but I think that the public's support for safeguarding remains completely solid, and I really want to just say thank you not only to our county council staff but all of the other organisations that take part in safeguarding. Thank you.
Thank you, Councillor Porter. Derek, would you like to present your report?
Chair, thank you very much indeed. Good afternoon, everybody. I will be brief. Before I start, can I just thank Councillor Porter for those comments? I will make sure that they are fed back to the partners. As part of the presentation, I will, to a degree, echo those sentiments in terms of what we have witnessed this year. The recommendations from the report today is that the Health and Wellbeing Board note the annual report of the Safeguarding Children's Partnership, note the successful transition from the arrangements that were changed in September 2019 when we were previously a board, now a partnership, and to note the impact on safeguarding this year of COVID-19. I appreciate that's very familiar to everybody on the call. As I said, I will be brief. This is a report that covers the last 6 months of the old arrangements and the first 6 months of the new arrangements through to the end of March 2020. We continue to work effectively, I believe, as a sovereign safeguarding partnership for Hampshire, but we also work very effectively alongside those safeguarding partnerships for Southampton, Portsmouth and the Isle of Wight. If I can just mention the content of the report without going through it page by page, as you would expect, it presents on the demographics of Hampshire, the structure of the partnership, how the partnership is funded, the training we undertake, and the audits we undertake. In particular, I draw people on the call's attention to the local safeguarding practice reviews. There is detail contained in the report. You will notice and hopefully be assured that it covers critical areas of safeguarding, including mental health and well-being, children in care, care leavers, those who are utilising early help facilities, those children and young people that are impacted upon by domestic abuse or exploitation. It deals with issues around children with disabilities and issues such as elective home education within the wider education system, and something that we cover, I think, in Hampshire very, very well indeed, which is around oversight of our children and young people that are in secure accommodation. The report covers the priority work of the board in 2019-20, including launching the family approach, around continuing to work around the ICON programme, abusive head trauma in young babies. If anybody who's not familiar with the programme, it is a groundbreaking programme that Hampshire has taken a lead on, and health colleagues have been particularly at the forefront of that excellent work. We also launched the Safe Sleep programme this year and continue to work on the critical area of neglect, both in terms of relaunching the strategy and the toolkit. We have sought to strengthen our assurance programmes, particularly the Keeping Children Safe, the Section 11 audit, and as I mentioned before, what were serious case reviews, now local child safeguarding practice reviews. The third priority for the year was around leadership and transformation, making that switch from the board to the partnership. Beyond that, I'm happy to take any questions anybody may have. I know this report was to the end of March. I can't not mention again the effects of the pandemic. It has put extra pressure on services, be that health, education, social care, our police colleagues. And I say this, a heartfelt appreciation of the response I have witnessed across the board since March. I have seen partnership elevated to a level I had not witnessed before. Police officers visiting vulnerable children at home on behalf of social care. The work of education in keeping line of sight into our vulnerable children has been absolutely superb. And just to echo the comments from the councillor right at the beginning, I think the work across the piece this year has been superb. There's no complacency in that at all, but I do believe the partnership is stronger than it's ever been. Happy to take any questions you may have, Chair. Thank you.
Thank you, Derek. Philip.
Thank you, Chair, and thank you for the report, Derek, and for all the work that's gone on. I know you talked about 3 priorities, and there are 3 priorities, but in paragraph 3.6 it refers to 4 priorities. I suspect that was no more than a typo. Can we just be absolutely clear, I'm not missing a 4th priority?
Absolutely, I think there are 3. I will have that double checked. I don't think you're missing a 4th. I'll take responsibility for that error and make sure it's amended accordingly.
Thank you. Anne.
Yes, just a quick question. Have temporary protection orders had to be extended because of problems with the courts?
I think Steve wants to answer that, but I could be wrong. Steve?
Do you want me to come in, because it's more of a technical local authority question than a safeguarding partnership question? Delays in the courts in Hampshire are not as bad as they are in many other parts of the country, but it has led to some extension of care proceedings. What there has been, and it won't be in the safeguarding partnership report because it's not in this year's data. If you saw it's in this year's data, not last year's. But what there has been is an increase in the complexity of casework that we're seeing at the front door, and probably the best evidence of that is the fact that in the whole of 2019, we had 5 police protection orders and 12 emergency protection orders. That's when we have to work alongside colleagues in police to protect children quickly in an emergency. In the first 9 months, so let's call it 9 months since the pandemic, we've had 62. So that tells you about the complexity of the work that we're getting, that families are really struggling in the context of COVID, and we're seeing more of the problems that lead to very significant family breakdown, and they're in the report, the issues around substance misuse, domestic abuse, and poor parental mental health, and those have been exacerbated and are leading to more and more complex casework at the front door.
Thank you, Steve. Graham.
Yeah, thank you, Chair. I just really want to speak in my capacity of Chair of the Hampshire Safeguarding Adults Board, and just to reiterate and underline the comments that Derek has made with regard to partnership working, and to also say that the work across children's safeguarding and adult safeguarding through the Think Family approaches that are adopted is also something that I think Hampshire is in a really good and strong place on. So those are the comments I just wanted to make in that capacity. Thank you.
Thank you. Roger, did you want to come in and ask a question?
Yes, not ask a question. I can answer a question. I've just spoken to the chairman of the East Hants bench, and there are no delays in the family courts that they are running.
Thank you, Roger. That's useful info. Steve, did you want to come back?
I'm sure Roger is right, but I wouldn't want people to think that there are no delays. There are some delays in some of our adoption proceedings are taking longer. That's probably not the East Hants bench, but we are seeing it elsewhere in Hampshire that certainly adoption is taking a bit longer to get through, and care orders are taking a bit longer to get through. Of course, whether that's because we've got more of them or because there's less capacity on the benches is a moot point, but it's an uneven picture across the place. So yeah, it's great that we've got no delays in East Hants, but there are some in some other places.
Thank you, Steve. I've got a random hand up, but no name attached to it. Again,
Liz, I think you'll find it's mine. Patricia.
Okay. Sorry, Patricia.
Yes.
Do come in.
Yeah, well, just about, it isn't a question, and we've already heard very positive things about the report and the programme this morning. But that is not to say we are in any way complacent. But I do want to take a few minutes of everyone's time to say a very special thank you to Derek in particular. You know, as the independent chairman of the partnership, he has a very rare skill of being able to pull together all the threads and get to keep people moving forward when lots of people have got many demands upon their time. So my sincere thanks to Derek, but also, of course, to all members of the partnership and all their teams, because this is a 24/7 service. You know, we don't hang up our hats and have a holiday, because these situations don't unfortunately have a holidays, and where there are holidays, very often those issues increase because of that. As Steve has already pointed out, we certainly had an increase in numbers being referred when the children went back to school and came out of their incarceration during lockdown. So we are certainly not complacent, but this is a very positive report, and I think this is a very good forum for us to say a huge thank you to all those people involved, and to say especially Derek, who steers the ship with great competency. Thank you.
Thank you, Patricia. Ray, did you want to come in very quickly?
Yes, thank you, Chairman. Very quick one. At the last, as Vice Chairman of the Children and Young People Select Committee, we reviewed the annual safeguarding report on the 11th of November in our last meeting. And so I mentioned that because I would also, as Vice Chairman, like to add my great thanks to our officers and to Derek and all other people who are involved in safeguarding of our youngsters. So I just wish to add that as an extra to what Councillor Jackie Porter has already said. Thank you, Chairman.
Thank you, Ray. If I take members to the recommendations, that we note the annual report, and we note the transition to the new arrangements, and we note that The report covers the year 2019-20 and the ongoing COVID-19 pandemic has impacted on requirements for service, and welcome the renewed commitment to partnership working. Rhys, do you want to take that through?
Thank you, Chair. I will again try and do this quickly. If anyone wishes to abstain from voting on this recommendation, please unmute and say so now. If anyone wishes to, thank you. If anyone wishes to disagree with this recommendation, please unmute and say so now. Thank you. And if anyone wishes to agree with this motion, please unmute and say so now.
Agree.
Agree.
This recommendation is agreed, Chair.
Thank you, Rhys. It's been a long morning, but we're on our final item now, item 10, our forward plan. Sumaya is telling me we've not yet set the calendar past March 2020 for the meeting, and I actually think we've got a potential agenda for the meeting in March. Is that right, Sumaya?
We do, yes. And then past March, as we agree the calendar a year at a time. So once it's been agreed, Christine, all of those dates will be added on to the document and filled out as we go. But right now we can only plan until March.
Okay.
Do you mean March 2021 though?
March 2021, yeah.
Yes, March 2021. Sorry.
That's the wrong year on it, doesn't it?
Yes.
Sorry, I will take credit for that one. I'll update that for the next meeting. Apologies.
Thank you. Is there anyone wishes to talk about future business items? Matt, I see you want.
So Maya mentioned at the beginning that transport was on the forward planner for March 2021, but I just couldn't see it on there.
Matt, it will be under the annual report. So each of the board sponsors will do a section and then we'll loop in transport colleagues as well.
That doesn't feel very satisfactory. That doesn't feel very satisfactory. Can we not just have an item on transport, please? I thought that's what we all said.
Can we have a look at that, Christine? And we'll see if it's possible.
Well, that, of course, I don't want to say no, but why on earth shouldn't it be possible? Why can't we just say yes now unless there's some bureaucratic reason why it can't?
There's no bureaucratic reason. It's a time limitation on how long our meetings are already.
Yes, but sometimes it depends on what's the most important things. We asked for this to come to this meeting. We asked for travel to come to this meeting and it didn't. I'm happy for it to come to the March meeting, but I don't want it to be bounced off yet again.
Well, it won't be if it's in one of the other reviews. Simon, let's just bring Simon in and see what he wants to say about it. Simon.
Yeah. Christine, Councillor Hess, we'll make sure. I mean, I'm absolutely with you, Christine. Transport's a really important issue. We'll make sure that is a feature of the next meeting and how we make sure that's emphasised. So, because it kind of feeds across all of our areas, there'll be an annual report on the whole kind of themes, but we'll make sure that transport is a key emphasis on as part of that.
So if it's not recorded on the forward planner, can that be reflected in the minutes?
I'm sure we can work with that, Samaya.
And yes, absolutely. I think it is reflected in there. Or does it not say transport as part of the annual report? Because I did note it in there specifically. I am confident of that, though my dates may be wrong. And Simon, yes, I will also note it in the minutes.
It is definitely in there. It says to include transport post-COVID economic recovery. So it is in there, Samaya.
Thank you, Julie.
But I think it's a different point that is being made in relation to, you know, if you cover it as part of an annual report and it's, you know, amongst other things, that's one thing. But actually, I think what board members were asking for was an item to really look closely at transport, and particularly because there's some quite key documents that are being prepared right now that will have an impact on health.
Yeah, so I think our plan was to tie it in across each of the themes of the board, because that's where we can fit it in where it's relevant, but we will certainly address it, and I'll note that in the minutes.
I think it's extremely important that we have a separate line on this forward plan, and it fits under strategic leadership precisely because it's a cross-cutting issue. And I would ask, please, if necessary for a vote to be taken at this meeting, that we simply have a line in there which says that as part under strategic leadership, there will be a separate agenda item on transport. I'm beginning to feel really annoyed about this because we've been raising transport as a health issue for 5 years that I've been on this board, and it's always pushed down the line and pushed down the line. And with the local transport plan 4 coming up, I do not want to fudge at yet another meeting.
Christine, I don't think we're trying to push it down the line by any means, but I see Simon wants to come in, so I'll let him. I'll defer.
So as I've picked up this kind of lead role in strategic leadership, I would play that in and work, and it will absolutely be kind of a sub item of that, so that it's a kind of a proper item to discuss, linking with Councillor Crampton and the communities work, because actually it plays into that as well. There's so many items, so we will make sure that there's a good discussion with our transport colleagues to take that forward. Christine, please be assured that I'll make sure that happens.
Thank you very much.
Okay, everyone else happy? So, right, I'm afraid we have finished very late. Had we been in Ashburton Hall, I'd have invited you all to have a mince pie with me to celebrate the last meeting of the year. So can I invite you to have a virtual mince pie and wish you all a very happy Christmas. And we will see you on the Thursday, the 18th of March, 2021 at 10 o'clock. Thank you.